Hello, dear friends. I am Dr. Jambukeswaran, Orthopedic faculty for you in Prepladder. Okay, so just in a short, we are going to do a rapid revision. Especially it's a image-based session. Most of the thing it will be image-based, not much of theory. Just I'll highlight you the very important points. It will be very useful for you, those who are preparing for this INI-CET. Fifth exam is coming, so INI-CET is fast approaching, and it will be very useful for you, right? So it's a sort of revision for you. So one thing, the request from the very beginning, dear friends, I can't go on seeing my mobile, and if the chat box and all, no, it may disrupt our flow. So just I will speak and I will discuss the thing. At the end 10 minutes I'll give you a time. Okay, so I will see the chat box and I'll answer your questions. Okay, straight away we'll move on to our first question. Okay, it's image based. It will be very interesting. Look at the diagram. Just you look at the diagram. You see this X-ray. The history. A 9-year-old boy. A 9-year-old boy had a history of fall on outstretched hand, sustained injury to his left upper limb. X-ray shows the following feature. Diagnosis, please. X-ray shows the following feature. Diagnosis, please. Look at the X-ray. Look at the X-ray. Okay, right. The choice A is shaft of humerus. Choice B is radial head fracture. Choice C is supracondylar fracture. Choice D is elbow dislocation. 4 choices, and obviously, easily you can rule out 2. Radial head appears normal, nothing to do with radial head. So obviously this is shaft of humerus. Everyone knows here is the shaft and nothing. So the problem for us whether this is a supracondylar fracture or an elbow dislocation. Okay, elbow dislocation. So it's very simple. You see here, I am able to see a proximal fragment here, a distal fragment here. Okay, just see a proximal fragment. The big fragment is a proximal fragment. That small one is the distal fragment. So this is very much above the condyles. This is very much above the condyles. When you see very carefully, this distal fragment is inside the olecranon and the joint is not displaced. So this should be supracondylar fracture. This is the right answer. Many of you would have guessed by this time. It's a very simple, but the same X-ray, the same thing may come in our INI-CET. Nowadays, dear friends, it's a image-based era. Okay, it's image-based era. In future years, lot of image-based question only we are going to get, and ortho is very simple. Okay, and all these topics which I am going to discuss now are repeatedly asked in the past 15 years in the INI-CET. Okay, take from me, dear friends, each and every topic have been repeated several times. In the future is this coming year also. Probably the same topics may get repeated, so it will be very useful for you. Kindly make notes, utilize this session. Okay, you see supracondylar fracture, right? And the second point, supracondylar, a 9-year-old boy. That gives a clue. Supracondylar fracture is the most common fractures of childhood. Point number 1 is most commonly occurs below 10 years. Book says more common in boys, more common on left side. You see? That's why I had given. All these are facts, all these are asked questions, dear friends. It's more common in boys, more common on left side. Common age is less than 10. And you know why supracondylar fracture is very common before in the children, especially below 10 years of age. Because the humerus, the anatomy of humerus, you say anatomy of humerus, when you just see the anatomy of an adult humerus and a child humerus, an autopsy, a real bone. Child humerus is little flatter, okay, and adult humerus is cylindrical. And you know there are 2 pipes are there, a flat pipe and a cylinder pipe, which is easy to bend. Flat pipes are easy to bend. So when a child falls down, the humerus is flat, easily that part, supracondylar area is flat, so go for a bending force, number 1. And 2 forces, coronoid fossa is there, olecranon fossa is there. So the bone is deficient in that area, number 2. And before 10 years, it's a growing bone. It's a growing bone. So what happens? It's a growing bone means it's actively, it's remodeling the area. The metaphyseal area is remodeling very actively. Epiphyseal metaphyseal junctions remodeling very actively. So the bone is weak. For these three reasons, whenever a child falls, fall on outstretched hand, the most common fracture is supracondylar fracture. Okay, supracondylar fracture is not that common in adults. Supracondylar fracture is a fracture of childhood below 10 years. That's why I had given, these are all important MCQs. 9 year is an MCQ, boy is an MCQ, and it's more common on left side is an MCQ, because whenever we fall, most of us are right-handed individual. So whenever you fall, no, the unwanted hand comes first for defense. It's very common nightstick fracture. I can say nightstick fracture. See, somebody is trying to hit you. You want to save the face. You are a right-handed individual. Reflexly, subconsciously, only the left hand will come for defense, for protection. Like that. So most of us, 90% individuals are right-handed individuals. So whenever we fall down, subconsciously, the left hand will come for defense. So left side is more common. So these 3 points. Okay. Right. So supracondylar fracture. Let me discuss you in short. What are the radiological findings of supracondylar fracture? I am going to show you 4 radiological findings of supracondylar fracture. All the 4 very, very important point for our NEET entrance, dear friends, NEET and INI-CET, next whatever it is. Okay. Number 1, you see here, this is a lateral view of a child's elbow. You are able to see this is the humerus. Okay, first I'll show this is the humerus. This is your radius. Here is your ulna. Okay, this is, you see, this is your ulna. This big thing is the ulna, small thing is the radius. This is your humerus, lower end of the humerus. Okay, I will rub it and I will show you again. When you see this very carefully, this is the diagram. So that diagram, I will explain the diagram, then you see in the X-ray exactly you will see. You are able to see something, okay, in the lateral view, a picture like this. Okay, a picture like this. Okay, you see here. The same thing in the X-ray, you see. It's coming like this, a band like thing, and something like this. Is it not looking like a teardrop? Is it not looking like a teardrop? Yes or no? Obviously, this looks like a teardrop, like an Indian oil symbol, teardrop. Okay, so this is teardrop sign. Okay, teardrop sign. This is called teardrop sign. What is the point, the concept I want to stress? A teardrop sign is a normal phenomena. Normally, this is a normal X-ray. This is a normal X-ray. Teardrop, a normal teardrop is seen. This is normal. Whenever supracondylar fracture happens, no, this teardrop is disturbed like this. So, what you want to write in the entrance, no, normal teardrop sign is disturbed. Is disturbed. That is the point. It is disturbed. Teardrop sign is disturbed. Many of the entrance books say teardrop sign seen. That is wrong. Teardrop sign seen normally in all of us. That should be disturbed by the fracture line. Then it is a point. Okay, normal teardrop sign is disturbed. First point. Second radiological sign. You see carefully. This is the proximal fragment. The big fragment is the proximal fragment. The small one is the distal fragment. Okay, supracondylar fracture has happened. This is the proximal fragment. This is the distal fragment. You just see the edges, end of the proximal fragment. You see here, the end of the proximal fragment is like this. Yes or no? It is compared with a fish tail like this. A fish tail like this. So this is called a fish tail sign. This is called a fish tail sign. The second sign of supracondylar fracture, fish tail sign. Okay, second radiological sign of supracondylar fracture, beautiful sign. One is a normal teardrop sign, disturbed. Number 2 is a fish tail sign. Okay, this is the second sign. Going to the third sign, you see here, carefully you should see, dear friends, you should see very carefully. You see here, see, able to see, this is your humerus, whole thing is your humerus, right? And this is your olecranon. Okay, so this is your capitulum of the humerus. This area is the capitulum of the humerus. If I draw, you can't see that. So just you see there is a overlap of the olecranon towards the capitulum. Capitulum comes this much, and olecranon overlaps. When it overlaps, here you can see a crescent shaped. First I had drawn, after that I will wipe. You can see very clearly a crescent shaped opacity is seen. Are you able to see here now? A crescent shaped opacity. This is called crescent sign. This is called a crescent sign, like a moon. Crescent sign, third radiological sign of supracondylar fracture. And the last radiological sign of supracondylar fracture, when you see in the lateral view, when you see this, this is your humerus, this is your ulna, this is your radius. Okay, here, right, you are able to see a blackish shadow on anterior aspect as well as a posterior aspect. An anterior aspect and a posterior aspect, right? This is a blackish shadow. This is called fat pad sign. This is called a fat pad sign. Okay, so 4 beautiful signs of supracondylar fracture, dear friends. Normal teardrop sign is disturbed. Fishtail sign is seen. Crescent sign is seen. This is anterior fat pad. This is posterior fat pad. So anterior, so here should be the fracture. Should be the fracture. You will get an anterior fat pad sign and a posterior fat pad sign. So fat pad sign. 4 beautiful radiological signs of supracondylar fracture. Actually, I don't want to discuss all these things here because we have to see as many MCQs as possible, but I can't avoid, because without this there is no supracondylar fracture MCQ as far as NEET is concerned, dear friends. Gartland's classification. Without Gartland classification, there are classification system for all the fractures, and all the fractures they are asking. Allman classification for clavicle, Neer's classification for proximal humerus, Gartland classification for supracondylar fracture, Mason's classification for radial head, Freichmann and Fernandez classifications are for distal radius. All these are asked question. I don't know, but this has been repeated several times, so concentrate. Only 3 types. Gartland classification is of type 1, type 2, type 3. Type 1, fracture is complete but undisplaced. Fracture is complete but undisplaced. Then it is type 1. Type 2, fracture is complete, it's partially displaced. You see, this is the anterior cortex. This is the posterior cortex. When you see the posterior cortex is intact, anterior cortex is open. Okay, and so this is called complete fracture with partial displacement. This is type 2. And when you see here, it is complete fracture, totally displaced, and this is type 3. This is type 3. What is the significance? Only when you know the Gartland classification, you can treat a child. For type 1, treatment is conservative. Conservative. Conservative means just above elbow POP slab, AE slab. Okay, this is the treatment of choice for type 1, no surgery. Type 2, you should try closed reduction. For type 2, you have to do a closed reduction, right? And internal fixation with K wires. So surgery is needed, type 2. Mostly this will settle with a percutaneous K wire, cross K wires. It will settle, okay? So this is type 2. Type 3, it is totally displaced, no other go, it needs an open reduction. I have to open the posterior aspect of the elbow. I should split or open the triceps, go to the lower end of the humerus in the supracondylar area, and I have to fix it. So this needs open reduction, internal fixation with KYS. You see, the treatment is so simple. This is what they are asking in the entrance. How will you treat a supracondylar fracture? Gartland type 1, conservative. Type 2, closed reduction, percutaneous pinning, K-wire fixation. Type 3, open reduction, internal fixation with KYS. That completes the treatment of supracondylar fracture. All the theories we can't discuss here, but image based, look at that. I told you in the very beginning, clinically, it's very difficult to differentiate elbow dislocation from supracondylar fracture. But when we follow certain methods, no, it's easy to diagnose. We won't miss clinically. Okay, obviously X-ray will show you that. Clinically, what's the difference? You look at the first picture. Look at the first picture. You see here, I am able to see the olecranon tip. It is little posterior. It is not in line with here. It is little posterior. So this is the attitude of an posterior elbow dislocation. Olecranon has slipped, humerus is pushed forward, olecranon is pushed backward posteriorly. So this is a posterior elbow dislocation. When you see here, this is the triceps tendon. This is the triceps tendon. So when olecranon is pushed posteriorly, triceps tendon gets loosened. It gets loosened here. When I flex my elbow here, dear friends, when I flex my elbow, it's very tight. If posterior dislocation happens, my olecranon will come here. So the lower portion of the triceps, it will become loose like a bowstring. When I do like this, a bowstring, right? So what happens? Bowstring sign. That's called a bowstring sign. That's called a bowstring sign. So this is a very practical clinical sign of elbow dislocation. Bowstring sign. It's called a, I have bow and arrow, bowstring sign. Right? Very practical sign of elbow dislocation, bowstring sign. Right? Number 2, at the same time, how a supracondylar fracture. You see here, this is the X-ray of elbow dislocation. You see the humerus had gone here, the olecranon is pushed down like this, posteriorly it is pushed. So this is a X-ray of posterior dislocation of the elbow. Commonest type of elbow dislocation is posterior, especially posterolateral. Yes, you see here, you look at this X-ray, I am able to see a S-shaped arm. The arm has become S-shaped. Whenever you get a child, in the lateral view, or ask the baby to sit in a stool, and you see from the lateral side, if the arm appears S-shaped like this, it should be supracondylar fracture. Because you see the proximal fragment pushed anteriorly, the distal fragment is pushed posteriorly. Distal fragment looks posteriorly. So this gives an S-shaped arm. It gives an S-shaped arm. Then it is supracondylar fracture. Right? And look at here. Another beautiful sign, a supracondylar fracture will show. Something looks like a dimple. Looks like a dimple. A puckering of skin is there. That's because the proximal fragment gets buttressed. Get buried. The proximal fragment gets buried in the brachialis tendon. Gets buried in the brachialis muscle. Okay, brachialis muscle. Then that gives a sign like a dimple, puckering. So this is called a dimple sign. This is called a dimple sign. Okay. So when you get an S-shaped arm and a dimple sign, clinically it is supracondylar fracture. When you get a bowstring sign, clinically that is an elbow dislocation. Okay. And the third important point, the most important point, is the 3 bony prominences. 3 bony points. Okay. What are the 3 bony points? Medial epicondyle, lateral epicondyle, and olecranon. Normally in us, when you flex the elbow, medial epicondyle, lateral epicondyle, and the olecranon, when you connect, you will get an isosceles triangle like this. Isosceles triangle like this. Okay. In supracondylar fracture, the supracondylar fracture is happening above the condyles. So the 3 bony points, the isosceles triangle, is not at all disturbed. It is not at all disturbed. It maintains, isosceles triangle is well maintained. What happens in elbow dislocation? See, the olecranon slips away. So what happens? The tip is not here. Everything comes to one line and the triangle is totally disturbed. The triangle is totally disturbed. You won't get that isosceles triangle. So on clinical examination, when the isosceles triangle is disturbed, it is elbow dislocation. When the isosceles triangle is well maintained, that is a supracondylar fracture. See, that's all clinically. Okay, very important things we had seen. Then, in humeral shaft fractures, look at the diagram, identify what is the fracture. Several times asked the question in NEET. Look at the X-ray. What is this? See, here is the supracondylar area. So this is not a supracondylar fracture. Well, in the shaft, especially it is in the lower end of the shaft. It's the lower end of the shaft. You're able to see a spiral, long oblique or spiral fracture. Okay, a long oblique or spiral fracture, the lower end of humerus, and radial nerve gets entrapped in this. And this X-ray is classically, this fracture is classically called Holstein-Lewis fracture. Holstein-Lewis fracture. It's called Holstein-Lewis fracture. Favorite question of NEET. What is Holstein-Lewis fracture? Distal third oblique or spiral fracture of the humeral shaft with entrapped radial nerve. That is called Holstein-Lewis fracture. That's called Holstein-Lewis fracture. Okay. Yes. You see, the next thing, what you are seeing, radial head I had given as a choice. But it is my duty to complete it. You see, radial head fracture, you are able to see a split here? Yes or no? Split here. This is a radial head fracture. In radial head fracture, the question they are asking is the classification. The classification is called Mason's classification. It is called Mason's classification. It is Mason's classification is for radial head fracture. Very simple, man. See, type 1, yes, just a split, single split fracture. That too, it is undisplaced. It is undisplaced. Then it is type 1. Type 2, single split fracture which is displaced. Intraarticular, it is displaced. What is the criteria to say it is displaced? Displacement means more than 2 millimeter gap. Whenever a fracture is there anywhere, whenever the gap is more than 2 millimeter, that fracture is called a displaced fracture. This has been asked once as an MCQ. Displacement, it is a significant gap more than 1 mm, 2 mm, 3 mm, 4 mm. That was a choice. So it is 2 mm. Very simple. Okay. So displaced. So a single split fracture which is displaced, it is type 2. Type 3, comminuted fracture, multiple fragments. It is type 3 Mason's. Type 4, any type of radial head fracture associated with elbow dislocation, that is type 4. So Mason's type 1 is split, undisplaced. Type 2, split, displaced. Type 3, comminuted. Type 4, radial head fracture associated with elbow dislocation. Okay, that completes the radial head fracture. For the treatment for a radial head fracture, no, if it is a single split, it is undisplaced, single split, okay, you can treat conservatively, above elbow POP slab. If it is displaced, you can fix it. If it is comminuted, the best treatment is excision of the radial head. Excision of the radial head. Because the problem, no, when you lead lot of multiple fragments inside that area, when the patient starts moving, this is a predisposing factor for myositis ossificans. A comminuted fracture radial head is a predisposing factor for myositis ossificans. Yes. Now, we'll move on to the second. So, we had covered few points, no? What is a supracondylar fracture? How it looks in the X-ray? What are the classical radiological signs of supracondylar fracture? How to differentiate supracondylar from elbow? Okay, we have seen. That's enough. Okay, see. The second thing, look at the diagram. Try to diagnose this fracture. Okay, a 32-year-old male. History of fall. Foosh means fall on outstretched hand. Has history of foosh, fall on outstretched hand. Sustained injury to the right forearm. X-ray shows the following feature. Diagnosis, please. Okay, see. Is it a Galeazzi fracture? Is it a Monteggia fracture? Is it a Essex-Lopresti fracture? Is it a Piedmont fracture? All these questions have been asked several times. Okay, I'll try to finish in a very short fraction. You see here, I am able to see a fracture. This is the radius. Okay, this is the ulna. Okay, you see, ulna is intact. Radius got fractured. First point. Ulna is intact, radius got fractured. And how is the fracture pattern? Fracture pattern is in the lower third of the radius. Fracture pattern is the lower third of the radius. And how is the radio-ulnar joint? Radio-ulnar joint. Radio-ulnar joint is otherwise called distal. It's a distal radio-ulnar joint. How many radio-ulnar joints are there? A proximal radio-ulnar joint, a distal radio-ulnar joint. Here the distal radio-ulnar joint is disrupted. Distal radio-ulnar joint is disrupted. So, what is this fracture? Fracture lower third radius with disruption of the distal radio-ulnar joint is called Galeazzi fracture. Is called Galeazzi fracture. So the right answer, it is Galeazzi fracture. It is Galeazzi fracture. Galeazzi fracture is fracture distal third radius with distal radio-ulnar joint disruption. Galeazzi fracture is otherwise called Piedmont fracture. Is otherwise called Piedmont fracture. Just to tell you this point, I had added that it is otherwise called Piedmont fracture. And Galeazzi fracture has one more name. This Galeazzi fracture is otherwise called fracture of necessity. Fracture of necessity. fracture of necessity. Okay, I will tell you the reason why that is called fracture of necessity in the next slide. So what are the synonyms for Galeazzi fracture? Galeazzi fracture, fracture of necessity, Piedmont fracture. Okay, yes. Monteggia's fracture is otherwise called treacherous fracture. Monteggia fracture is otherwise called treacherous fracture. Yes, you see here. Look at the diagram. Look at the diagram. You compare so that you will never forget. Okay, very, very simple. Ortho is simple. A distal third radius fracture with disruption of the distal radial ulnar joint. This is called Galeazzi fracture. Just exact opposite to that, you see proximal third fracture of the ulna with radial head subluxation. With radial head subluxation. This is called Monteggia. This is called Monteggia. So I repeat once again, dear friends, what is Galeazzi? Distal third radial fracture with disruption of the distal radial ulnar joint is called Galeazzi. Proximal third ulna fracture with disruption of the proximal radial ulnar joint, otherwise radial head disruption, is called Monteggia. Exact opposite to Galeazzi, Monteggia. Okay, so this difference you should know. In between this Galeazzi and Monteggia, another one confusing guy is there and not asked several times in our entrance. So I am expecting this question very soon. This fracture, you look at this fracture. What is Galeazzi? What is Galeazzi? It is distal third radial fracture with distal radial ulnar joint disruption. It's called Galeazzi fracture. Okay. Monteggia is proximal third ulna with proximal radial ulnar joint disruption. That is called Monteggia. Okay. In between, you see here, there is a fracture, comminuted fracture of the radial head. Comminuted fracture of the radial head with disruption of the distal radial ulnar joint. Drudge. What is this fracture? Comminuted fracture of the radial head with disruption of the distal radial ulnar joint. With disruption of the distal radial ulnar joint. This is called Essex Lopresti fracture. Essex Lopresti fracture. So far, this they had not asked several times in the entrance. Okay. This is called Essex Lopresti fracture. One more thing, just I want to tell you here. Okay, you see here. You look at this diagram. I want you to teach you one thing. This Monteggia's fracture is otherwise called treacherous fracture. Treacherous means cheating. Treacherous means cheating. Treacher means cheater. Treacherous means cheating fracture. Okay, so who is a treacher? Traitor. Okay. So he is called a traitor or a treacher, treacherous fracture. Okay. So treacherous means cheating. Which can cheat you? Ulna fracture. This proximal third ulna. Anybody can diagnose this ulna fracture. Anybody can diagnose this ulna fracture. But many may miss the radial head subluxation. Many may miss the radial head subluxation. Okay. So proximal third ulna fracture with radial head subluxation. Radial head subluxation. Right. See, this radial head subluxation is often missed. Radial head subluxation is often missed. Okay. How to avoid this missing? How not to get cheated? Okay. There comes a line called McLaughlin's line. L-A-U-G-H-L-I-N. McLaughlin. Please record this word. This is an expected question in Monteggia's fracture, forearm fracture, McLaughlin's line. When we follow this McLaughlin's line, we will never miss a Monteggia's fracture. Okay. We all know fracture happens here in the ulna. You are drawing a line in the mid shaft of the radius like this. It should go and cut the capitulum. Capitulum is here. Capitulum is here. Okay. This line normally should go and cut the capitulum. If it is a radial head subluxation, radial head should be here. Radial head is subluxated here. So when you draw a straight line in the mid shaft of the radius, this will not go and cut the capitulum is here. So it is not cutting the capitulum. So capitulum is missed. So this is a McLaughlin's line positive. So what does it signify? Radial head is not in its original position. It is subluxated. So when you follow this McLaughlin's line, Monteggia fracture cannot cheat us. So how they will ask you this as a new MCQ in NEET? McLaughlin's line is significant in Galeaci, Monteggia, Essex, Lopresti, some other fracture they will give. So the answer is Monteggia. Okay. And I told you one important thing. Galeaci fracture is called fracture of necessity. Why? Because you see, okay, so you see, you see here, this Monteggia's fracture, coming to why this Galeaci is called fracture of necessity. Monteggia's fracture can be treated conservatively. Monteggia fracture happening in a child, better this can be treated conservatively. Whereas Galeaci fracture, 100% needs open reduction and internal fixation. 100% needs surgery. Surgery is 100% necessary for Galeaci fracture. So it is called fracture of necessity. Okay. Dear friends, please record in your diary, in your notes, no? There are two fractures of necessities in orthopedics. Two fractures of necessities. If that fracture happens, surgery is a must, 100%. Number one, Galeaci fracture. Number two, lateral condyle fracture in a child. What are the two fractures of necessity? It is lateral condyle fracture in a child. Number two, Galeaci fracture. Okay, right. We will move on to the next question. Okay, next question. You see, again, very, very important topics. All are very important topics in case of, all are very important topics. Only the NEET INI-CET question I am discussing. Okay. So this is very important. Again, you concentrate. A 60-year-old female, okay, had history of fall on outstretched hand. Sustained injury to the left wrist. Okay. X-ray shows the following feature. Diagnosis, please. History on fall on outstretched hand. 60-year-old female. That's very important. Elderly female. Here had history of fall on outstretched hand. Okay, the X-ray shows the following. Diagnosis, please. You look at this X-ray. Is this a Barton fracture? Is this a Colles fracture? Is this a Smith fracture? Is this a Schaffer fracture? Okay, I will explain now. You see this X-ray, dear friends. The fracture is in the distal third. It is not involving the articular surface. This is the articular surface. Okay. The fracture is purely here. It is not extending into the articular surface. Okay. It's not extending. You carefully watch. Easily you can see. Okay. You carefully watch here. Easily you can see. Fracture is in the distal radius. It is not involving the articular surface. Second point, on lateral view, proximal fragment is here. This is the distal fragment. Distal fragment is displaced dorsally. This is the lateral view. This is the dorsal aspect. This is the volar aspect. So the distal fragment is displaced dorsally. So a distal radial fracture which is displaced dorsally, distal fragment displaced dorsally, which is not involving the articular surface, that should be a Colles fracture. That is the commonest fracture in elderly. Okay. 1 minute. Please. Okay, so this is, okay, so elderly, right? So the most common, I will tell you few important, 4 important MCQ, dear friends. Most common fracture of childhood supracondylar. Most common fracture of adults or adolescents scaphoid. Most common fracture of elderly Colles. Most common fracture of newborn clavicle. I repeat once again, dear friends. Most common fracture of newborn clavicle. Most common fracture of children supracondylar. Most common fracture of young adults scaphoid. Most common fracture of elderly Colles. See a correlation. All these most common fractures are happening in upper limb. It's a coincidence. Easily we can. Now let us see about Colles fracture. How to differentiate Colles from Smith. How to differentiate Colles from Barton's, and what is Schaffer's. Okay. So I will show you. Beautiful x-rays. Okay. Whenever a patient falls on outstretched hand, especially in extension like this, okay, there will be Colles fracture. If a patient falls on flexion like this, you won't believe, today morning in my OPD, in my government medical college, my OPD, okay, a 30-year-old man who is working in our hospital came with history of fallen outstretched hand with the flexion. He gave the history by himself. Doctor, I had fallen like this. In flexion. Then it will end up in what is called a Smith fracture. Smith fracture is otherwise called reverse Colles. Smith is otherwise called reverse Colles. Okay. So whenever in case of when fallen outstretched hand in a flexed wrist will end up in Smith fracture. Fallen outstretched hand in extended wrist will end up in Colles fracture. Okay, now I will show you the x-rays so that you will never forget. Very, very simple. You see, dear friends, it's very simple. A distal radial fracture on the lateral view, the distal fragment is displaced dorsally. This is called Colles fracture. The same thing on the lateral view, when you see the distal fragment is displaced volar aspect, the flexor aspect. Okay, so this is called Smith. Okay, reverse Colles, Smith fracture. The third thing, it is a distal radial fracture. I am able to see a split starting here and it's going up, and it extends into the joint. I am able to see this fracture splits and it enters the joint. This is called, whenever there is intra-articular involvement, this is called Barton. This is the basic difference, dear friends. A distal radial fracture which is extra-articular is called Colles and it should have a dorsal displacement. A distal radial fracture which is extra-articular with a volar displacement is called Smith. A distal radial fracture which has intra-articular extension is called Barton. It's called Barton. And last but not the least, you are able to see a fracture here, and fracture involves only the radial styloid. And that is called a radial styloid fracture is otherwise called Schaffer fracture. We all know why this name Schaffer and all. Okay, so very simple, right? Schaffer, you know who is a Schaffer? Schaffer is he's a driver. Okay, a high class driver is called a chauffeur. Okay, in English, no, the words will change. Somebody's just cooking in a roadside stall, he's called a cook. If the same guy who works in a 5-star hotel is called a chef, like that, somebody is driving a simple car, it's called a driver. Somebody drives a Merc or a BMW, he's called a chauffeur. Okay, English, the words change, the purpose is same. Okay, chauffeur. So whoever it is, they should drive carefully. That is the take home message. Okay, right? Chauffeur is nothing but a driver. Why this radial styloid fracture is called a Schaffer's fracture? Olden days, this won't apply now. Olden days, before Henry Ford era, we all know who was Henry Ford. Henry Ford was a founder, a chairman of the Ford car company. Okay, Ford, the great Ford car company, Henry Ford. He was the man who invented the self-starter, ignition, key. You are putting a key and starting the car. That's called self-starter or ignition. He was the person who invented that. Before Henry Ford, each and every time to start a car, somebody has to come in front, a driver, obviously olden days driver has to come in front of the engine. Okay, near the bumper hole will be there. They'll put a rod like thing that's technically called handle. They have to start that like a generator. They start like a generator, right? Once the engine got started, no, this handle will give a backfire and it will come and hit the radial styloid. So just you would have watched this during old vintage pictures like a Titanic, no, old cars, black color car, the British car, they will put a handle, they will start like this. Once engine gets started, it will give a backfire to the radial styloid. Again and again, this will be repeatedly. Olden days, drivers used to sustain this radial styloid fracture, so that was called Schaffer's fracture. Okay, that was called Schaffer's fracture or radial styloid fracture. Nowadays, ignition, no problem. Okay, so it's called a Schaffer's fracture. Now you see the difference. A distal radial fracture which is extra-articular dorsal displacement, Colles. A distal radial fracture which is extra-articular ventral displacement, that's called Smith or reverse Colles. A distal radial fracture which has intra-articular extension, that's called Barton. A distal radial fracture which involves only the radial styloid is called Schafer's. Okay, the difference between Colles and Barton, common fractures in our practice, daily we will see cases. The difference is, since Colles is extra-articular, treatment of choice conservative. Barton is involving the joint, intra-articular, so it should be perfect anatomical reduction is needed. Otherwise, joint congruity is lost and the patient will go for wrist arthritis. So, Barton fracture has to be operated. So, treatment of choice for Barton fracture is surgical. Okay, surgical. Open reduction, internal fixation with a T-buttress plate. How many times they had asked this question? T-buttress plating. Okay, so Barton fracture, buttress plating is the treatment of choice. Colles fracture, conservative, POP, below elbow POP cast. That's called Colles cast. I will show you the diagram. You see the diagram. The classical deformity of Colles fracture because of dorsal displacement, this is called dinner fork deformity. How many times they had asked this again they will ask you in image based question. Dinner fork deformity, like a dinner fork because of dorsal displacement, right? And see, this is the dorsal displacement in the x-ray and this is causing this deformity in that patient. Okay, dinner fork compared with the dinner fork, so it's called dinner fork deformity. And the treatment of choice for Colles fracture is conservative. I told you this is called Colles cast. You see this cast, two positions, just observe this. See, the wrist is flexed palmarly, palmar flexion, and the disc is it is shifted in ulnar. So, one second, yeah. So it is palmar flexion, ulnar deviation. It is palmar flexion, ulnar deviation. Below elbow cast in palmar flexion and ulnar deviation is called Colles cast. This is called Colles cast. Okay, that's called Colles cast. You see here, before applying Colles cast, you should know the classical displacements, 6 deformities or 6 displacements of Colles fracture, and that is called, you should remember in this mnemonics, you can remember this, DILS. Okay, DILS. All the displacements refers to the displacement of the distal fragment, not the proximal fragment, distal fragment. You see, this is the small chip, this fragment is the distal fragment. Okay, the whole big thing is the proximal fragment. So the displacement of distal fragment, the reference is displacement of the distal fragment. D stands for dorsal tilt. All these are asked question, man. I can't leave, I don't know. Dorsal tilt. Then comes dorsal displacement. Dorsal displacement. The I stands for impaction. L stands for lateral tilt and lateral displacement. Very simple. Lateral displacement. Okay. S stands for supination. I may be having a horrible handwriting, please adjust with me. Okay, so in the very beginning my handwriting is like this only. See, dinner fork deformity. D, dorsal tilt, dorsal displacement. I, impaction. L, lateral tilt, lateral displacement. S, supination. DILS. See, these are the classical displacements that happens in all Colles fracture. Because of this dorsal tilt and dorsal displacement, you are getting the dinner fork deformity. When you understand this, when you give counter forces and reduce and apply a POP slab, that is called Colles cast. You should neutralize all these displacements. Yes or no? So, you see, very, very simple. Dorsal tilt and dorsal displacement is neutralized by palmar flexion. Lateral tilt and lateral displacement is neutralized by ulnar deviation. This is this ulnar deviation. Okay. And you see how that it is given. The cast, this is supination, this is pronation. Cast is kept in pronation. So cast is applied in pronation, that neutralizes the supination. before applying POP, the basic thing what we will do, one guy will hold here, another guy will hold here. We will give traction, yes or no? We will give traction and counter traction. So traction will neutralize the impaction. You see, all the displacing forces are neutralized. You look at that Colles cast. Below elbow POP cast given in traction, kept in palmar flexion, ulnar deviation. Palmar flexion neutralizes the dorsal tilt, dorsal displacement. Ulnar deviation neutralizes the lateral tilt, lateral displacement. The cast is given in pronation, that neutralizes the supination, and your traction neutralizes the impaction. All the displacing forces are neutralized and patient will have an excellent result. It is extra-articular. So minimal malunion may be there, doesn't matter. It will unite 100% and has a very good prognosis. Yes. So this is about Colles. Now we will move on to the next question. A 20-year-old college student had history of fall on outstretched. You look at the age group, you follow the age group, that's very important. A 20-year-old college student had history of fall on outstretched hand. And he sustained injury to the right wrist. X-ray shows the following feature. Is this a scaphoid fracture? Is this a lunate fracture? Is this a Bennett fracture? Or is this a Rolando fracture? 4 choices I had given. Okay, you see. You look at this diagram. Okay, you look at this diagram. I am able to see this is radius. This is ulna. I am able to see your mnemonic. Please try loose shirt. Pisiform, triquetrum, lunate, scaphoid. Okay. Okay. Scaphoid. I am able to see a fracture line in the scaphoid. This is the scaphoid. The whole bone. This is the scaphoid. I am able to see a fracture line in the waist of the scaphoid. So obviously this is a scaphoid fracture. This is a scaphoid fracture. What I told, most common fracture of young adults, or adolescents or young adults, 20-year-old. Because Colles fracture is uncommon in this age. Colles fracture happens in elderly. Okay, let us see about the scaphoid fracture. You see, scaphoid fracture, I will tell you, most common fracture of young adults and adolescents. There are 8 carpal bones in human body. The most common carpal bone to undergo fracture is scaphoid. You should understand, whenever you understand the concept, no, probably in UG they would have taught you all these things. Okay, it's my duty to just recollect and tell you, right? See, the concept is very important, man. Once you had understood the concept, no need to memorize. Even after 20 years, somebody asks, just like that, the subject will come to us. Okay, you see, there are 8 carpal bones in human body. Whenever I fall down, the most common carpal bone to get fractured is scaphoid. Most common carpal bone to get dislocated is lunate. 2 MCQs. Most common carpal bone to undergo fracture is scaphoid. Most common fracture to undergo dislocation is lunate. Why? Scaphoid is the most common carpal bone to get fracture. When you just please understand, dear friends, only in anatomy they had taught this scaphoid lies in the proximal row. Never. Okay, never. No ortho books this is a scaphoid view. This is not a AP view, this is a scaphoid view. When you take in anteroposterior, just simple AP view, scaphoid never lies in proximal row, scaphoid never lies in distal row. Scaphoid is the only carpal bone to lie in both rows. Both rows. Because when you see, proximal, there is the part anatomy, only carpal bone to have a part like this. Proximal pole, distal pole, waist. 3 parts, all the anatomy, B.D. Chaurasia, Inderbir Singh, Vishram Singh, Grace, Cunningham's, all the anatomy books are given. Scaphoid is one carpal bone with these parts, proximal pole, distal pole. They had not mentioned anything for capitate, a proximal pole, distal pole, nothing like that. Why they had mentioned? Because proximal pole lies on proximal row, distal pole lies on distal row, waist of scaphoid is unsupported. So whenever I fall down, waist is gone. This is the reason, dear friends, why most common carpal bone to get fractured is scaphoid. Okay, waist is unsupported. Proximal pole lies strongly on proximal row. Distal pole lies on distal row. Support is there. Waist is unsupported. Waist of scaphoid is unsupported. So most common site to undergo fracture of scaphoid, 70% of scaphoid fracture happens in the waist. Okay, waist. Then the next site is proximal pole, the least common site is distal pole. Okay, and very peculiarly you see here, you want to take an what's the best view for scaphoid? It's called a scaphoid view. It's a sort of oblique view. You should place the arm like this, then you should expose, you can see a scaphoid fracture. Okay, so the view is called scaphoid view. That is the ideal view. Like Colles fracture, it has a classical deformity, and that is called dinner fork deformity. Dinner fork deformity. Is there any classical deformity for scaphoid fracture? Yes, dear friends, there is a classical deformity for scaphoid fracture. If it is undisplaced, this is an undisplaced fracture. You see, the scaphoid is not displaced. The shape of the scaphoid is maintained. Only a fracture I am able to see here. So it is undisplaced. Okay. If it is displaced totally, this is giving a deformity. So this is the scaphoid fracture. You see, it's giving a deformity like this. Okay, like this. I will draw once again and I will show you. It is like this. Is it not looking like a humpback? Is it not looking like a humpback? So this is called humpback deformity. If they ask in MCQ, humpback deformity, in which fracture it happens? Humpback deformity happens in displaced scaphoid fracture. Happens in displaced scaphoid fracture. What are the problems in scaphoid fracture? What is the problem in scaphoid fracture? Scaphoid is a very small bone. In private practice, I am very scared about scaphoid fracture. It's a very small bone, but causes a big problem. Why? All orthopedicians are very scared of scaphoid fracture. Problem number one, it happens in young adults. Young adults. And naturally, you see the blood supply. You see the blood supply. This is the scaphoid bone. This is the scaphoid bone. This is one view. This is another view. This is the scaphoid bone. Okay, scaphoid bone. When you see what happens, the superficial palmar branch of radial artery enters the distal pole of scaphoid. The main blood supply of scaphoid bone is radial artery. Radial artery gives two branches. One is a superficial palmar branch. Another is a dorsal carpal branch. The dorsal carpal branch also enters through the distal pole. So when you see the superficial palmar branch of radial artery enters through the distal pole, the dorsal carpal branch of radial artery also enters through the distal pole of the scaphoid. So scaphoid is like this. Scaphoid is like this. You see, both the vessels enters through the distal pole. Both the vessels enters through the distal pole. Okay. Now 70% of fracture scaphoid happens in the waist. So blood supply is lost to the proximal pole. So proximal pole is going for avascular necrosis. Proximal pole is going for avascular necrosis. However well you treat a scaphoid fracture, dear friends, there are chances of 40% of avascular necrosis of proximal pole of scaphoid. Proximal pole of scaphoid. This is the problem. Okay, 40%. That is why we are very bothered about a small bone. Fracture tibia, we are not scared. Fracture shaft of femur, probably fat embolism happens, that okay. But we know, okay, fracture both bone forearm, very happy. Volar Barton, very, very happy. But scaphoid, we are very scared. The reason is, however experienced orthopedician, however good you treat, there is a chance 40% avascular necrosis of proximal pole of scaphoid, and this goes by a name. AVN of proximal pole of scaphoid is called Preecier's disease. Preecier's disease. Okay, Preecier's disease. Asked question. Avascular necrosis. Many names are there. Avascular necrosis of head of femur is called Perthy. Avascular necrosis of patella is called Sinding, Larson, Johansson. Avascular necrosis of tibial tuberosity is called Osgood Slater. Avascular necrosis of calcaneum is called Seaver. Second metatarsal is called Freeberg. Fifth metatarsal is called Eileen. Avascular necrosis of capitulum is called Panners. Avascular necrosis of proximal pole of scaphoid is called Preecier. Avascular necrosis of clavicle is called Fredericks. Avascular necrosis of the spine, two things are there, Calvus and Schuermann. So it goes, okay, it goes like that. Okay, many points are there. So now you are remembering one, Preecier's disease, a precious point I can say you. 40% chance of avascular, that is the problem. of thing. So you should be very clear whether the fracture is displaced or undisplaced. If it is undisplaced fracture, you can try what is called a scaphoid cast. This is called a scaphoid cast. That is the treatment of choice, scaphoid cast. How long you should give? Probably this is the maximum time of immobilization. Standard ortho textbook says 10 weeks. Even for a big bone like tibia or forearm or ulnar radius, bones, they will say maximum 6 to 8 weeks. For such a small bone, 10 weeks of immobilization because of the fear of avian. When it get displaced, what will happen? Okay, so this is called a scaphoid. You look at the thing, image, you look at the image, that is called a scaphoid cast. Okay, this is called a, and how it looks. Is it not looking like holding a tumbler? Okay, holding a tumbler or looking like a glass. So this is called glass holding position. Scaphoid cast is a below elbow cast which applied in a glass holding position. Okay, exact thing they will ask in image based question. Glass holding position. Okay, glass holding position. And this goes by a name. Okay, Bowler, B-O-H-L-E-R, Bowler gauntlet, G-A-U-N-T-L-E-T, gauntlet cast. Okay, so scaphoid cast, glass holding cast, glass holding position. The cast is called Bowler gauntlet cast. That is the treatment of choice for undisplaced scaphoid fracture. Undisplaced. If the proximal pole distal from the waist, it gets even minimal displacement is there. It is open reduction, internal fixation or percutaneous fixation. Okay, best is to open. Best is to open. The practical things you don't need. So it's open reduction, internal fixation with a screw. With a screw. You see the screw. This is scaphoid. And look at the very peculiar thing, no? This is the scaphoid. Screw, whenever, look at this screw, this is very peculiar. A screw, normal screw we had seen, it will have a head like this, a body like this, then some. So this is what a normal screw. A head will be there. Here the head is missing. This head is missing. Yes or no? So this is a headless screw. And this screw is called Herbert screw. 1 lakh time repeated NEET entrance question. Herbert's screw. Okay, H-E-R. Herbert screw. Herbert screw is an headless screw. Why? It gets, because if there is no head, you can bury that inside the bone. So you see, scaphoid is here. The screw is buried inside that. Okay, the screw is buried inside that. So no need to remove the screw, and you are not supposed to remove the implant. Okay, this is called Herbert screw. So for a displaced scaphoid fracture, Herbert screw fixation is the treatment of choice. What does this image says? What does this image gives? So obviously this is showing, this is the radius, this is the scaphoid, this is the scaphoid, and you are seeing a scaphoid. Fracture has happened here, and you see the edges. You see the edges are sclerosed. There is a gap. So this is called non-union scaphoid. This is called non-union of scaphoid. How to say it is non-union? I am able to see a gap there, and the edges of the fragments are, you see, sclerosed, white in color, sclerosed. So this is non-union scaphoid. This is non-union scaphoid. If you don't immobilize properly, it will go for non-union. It will go for non-union. Because blood supply is lost, waste is gone. And look at this last picture. Look at this last picture. You see the scaphoid, it has shrunken. It has shrunken. It is not having, see, it is not having the shape like this. See how much elongated this bone is, scaphoid. It is shrunken. You compare that, it is shrunken. And when you carefully, you see, no, proximal, the distal pole I am seeing here, this big. And proximal pole is almost absorbed. I am not able to see any proximal pole. I am not able to see any proximal pole. Okay. So this is called avascular necrosis of proximal pole of scaphoid. And this is the classical picture of Precier. This is the classical picture of Precious. Okay. Avian. So these are all the complications. If it is an undisplaced scaphoid fracture, you can give a Colles, you can give a scaphoid cast. If the displaced scaphoid fracture, immediately better do a Herbert screw fixation. Otherwise, it will go for non-union, or it can go for avascular necrosis of proximal pole of scaphoid, which is called presear. You see, the scaphoid is collapsed. You are not able to see, 40% chance. And coming to this lunate dislocation, just see the image. This is a diagrammatic representation. This is the radius. This is the lunate. This is the capitate. These are the metacarpals. Metacarpals. Okay, metacarpals. This is the capitate. Lunate is dislocated. You see the X-ray clearly. You should know how to differentiate. In lunate, you can see only in lateral view. This is the radius. This is the capitate. Okay, these are your metacarpals. You see, lunate should sit here. Instead of that, it has slipped. It has come out. You see, it has dislocated. Okay, so this is called lunate dislocation. So I told you, no? I told you, okay? I told you, the most common carpal bone to get dislocated is lunate. What is the complication of lunate dislocation, or which nerve is injured in lunate dislocation? Deep branch of ulnar nerve. Deep branch of ulnar nerve. Colles fracture, what is the nerve that is commonly damaged? Any wrist injury, the most common nerve that is damaged is median nerve, and that is called carpal tunnel syndrome. Okay, in lunate dislocation, it's very, very peculiar. It is causing compression of the deep branch of ulnar nerve. This has been asked several times. Okay, and two more things. The metacarpal fractures, when we finish now, most of the fractures in upper limb we are covering. You see here, I am able to see a fracture which is a comminuted fracture. Here one fracture line, here one fracture line. Okay, so you see this is blurred. This is the fracture line. This is the fracture line. It is blurred here. So just see in the small diagram, I am seeing a comminuted fracture in base of the first metacarpal. I am able to see a comminuted fracture in base of the first metacarpal. This is called Rolando. This is called Rolando. Rolando's fracture. At the same time, when I am able to see just a simple oblique, only one piece, oblique piece on the base of the first metacarpal, this is called Bennett. This is called Bennett fracture. Okay, Bennett fracture. Often asked questions. What is Rolando? What is Bennett? Bennett fracture is oblique fracture. Both are intra-articular, dear friends. Because I had seen two MCQ books wrongly given. One is intra-articular, one is external. No, never, never. Both Rolando and Bennett are intra-articular fracture, dear friends. If it is comminuted intra-articular, it is called Rolando. Oblique intra-articular, it is called Bennett. The problem with Bennett and the repeated question is, you see Bennett fracture, no? Bennett fracture. This is a diagrammatic representation of Bennett fracture. See, this oblique fracture line is here. Okay, oblique fracture line is here. This small piece is the proximal pole. This big metacarpal is the distal pole. Distal pole is attached to a tendon, and the tendon is abductor pollicis longus. The tendon is abductor pollicis longus tendon. Abductor pollicis longus tendon. So the abductor pollicis longus tendon constantly pulls the distal pole. So if you don't fix this fracture, this may go for non-union. The problem in healing, why Bennett is not healing that easily, is because of, this is the question, because of pull of abductor pollicis longus tendon in the distal pole. Okay, that's so the treatment of choice for Bennett fracture is K-wire fixation. Treatment of choice for Rolando fracture is mini screw fixation, because it is thrown into multiple fragments, so you cannot be fixed with a small K-wire. Better to fix it with a mini screw fixation. Okay, right. Coming to the next question, just you see this, just you see this, you see a 27-year-old college student, okay, a 27-year-old college student had a history of fall from bike, sustained injury to the right shoulder. He is not able to touch the opposite shoulder. So he has sustained injury to the shoulder. Somehow he is feeling instability of the shoulder. When you ask him to touch the opposite shoulder, patient is not able to touch the opposite shoulder. What is this called? This is called Dugas test. This one simple thing is enough to diagnose that this guy is having a shoulder dislocation. Okay. And this is his third episode within a period of 12 months. So more than 2 times in 12 months, the shoulder is getting dislocated. That is not a simple shoulder dislocation. That is recurrent shoulder dislocation. That is recurrent shoulder dislocation. So look at the Diagram give the diagnosis. What I am able to see, this is the glenoid cavity. This is the head of the humerus. Okay, shoulder joint, head of the humerus. In head of humerus, I am able to see a dip or a dimple here, a defect here, and this is called Hill-Sachs lesion. This is called Hill-Sachs. I will teach you once again. Hill-Sachs lesion. This is called a Hill-Sachs lesion. So the diagnosis is a recurrent shoulder dislocation. To diagnose recurrent shoulder dislocation, you should know two important, because I had seen the past 15 years question bank of INI-CET aims. Okay, how many times they had asked this recurrent shoulder dislocation, these two topics. Okay, should be very thorough, dear friends. This year also, this is going to come. Very simple, very simple. You see, you should know Bankhart's lesion. What do you mean by Bankhart's lesion? Bankhart's lesion is a soft tissue lesion. Soft tissue lesion. Hill-Sachs lesion is a bony lesion. It is a bony lesion. So that is, Bankhart's is a soft tissue lesion, Hill-Sachs is a bony lesion. Basic difference. Okay, what is this? What soft tissue lesion is happening in Bankhart's? It is damage that is happening to the anterior structures. Anterior structure means capsule and labrum. Where it is happening? In the anterior structure means which part of the anterior structure it is happening? It is happening, just I used to always have a mnemonic, no? B stands for Bankhart's, A-I. I used to read when I was a UG and I was preparing for my entrance like you. I know your feeling, dear friends, in what mindset you will be there. Okay, I can understand. I am able to perceive, okay, your feelings, because I had suffered a lot to get a seat, and I know the weightage of entrance preparation time, how I know your mental agony, everything I can understand. From my side, what I can do as a teacher, I can make your things very simple for you. I can to teach. So please have this mnemonic. The same thing which in Chennai, when I was preparing for my entrance, I made this mnemonic for myself. BAI is one mnemonic. Okay, bye. Okay, bye. A mnemonic. HPL. It's a very famous computer company, Hewlett-Packard Limited, HPL. Two mnemonics are there. When you remember this BAI and HPL, this confusing thing will become so easy for you. B stands for Bankhart's lesion, and I told it's a soft tissue lesion. Where it is happening? It's happening in the anterior structure, that is capsule and labrum. When there is a defect in antero-inferior aspect of the capsule and labrum. When there is a defect in antero-inferior aspect of the capsule and the labrum, that is called Bankhart's lesion. Now you understood what is BAI? BAI stands for, okay, Bankhart's antero-inferior. Okay, inferior. Lesion in the capsule and labrum. Okay, and the mnemonic which I told for Hill-Sachs lesion is HPL. HPL. Hill-Sachs is a bony lesion which is a defect that is happening in posterolateral aspect of the head of the humerus. Posterolateral aspect. You see, this is the X-ray. See, this is the X-ray. This is a real autopsy humerus, dear friends, which is having a Hill-Sachs. Are you able to see a dimple, a depression here? You are able to see a depression, a dip here. That is Hill-Sachs lesion. Where whenever in a head of humerus, when you are getting a dip or a defect in posterolateral aspect of head of humerus, that is called Hill-Sachs lesion. Whenever there is a damage in capsule and labrum and antero-inferior aspect, that is called Bankhart's. BAI, HPL. This often confuses. They are giving Hill-Sachs antero-inferiorly, posterolaterally, mediolaterally, something like that. So whatever they confuse, when we have a mnemonic, they can't confuse. This is a sure question, dear friends. And this Hill-Sachs lesion is otherwise called Hatchet deformity. This Hill-Sachs lesion is otherwise called Hatchet deformity. This deformity has a new name, Hatchet deformity. This is given only in aptly, not in most of the MCQ guides. So this is an aptly's point. Hatchet deformity is the other name for Hill-Sachs deformity. It's the other name for Hill-Sachs deformity. Now you should know, what do you mean by terrible triad of shoulder? Terrible triad is otherwise called unhappy triad. Okay. Terrible triad is otherwise called unhappy triad. Terrible. What are the three? Triad means three things. Okay. One, erosion of the glenoid rim. Erosion of the glenoid rim. Number one. Number two, Bankhart's lesion. Bankhart's lesion. Number three, Hill-Sachs lesion. Hill-Sachs lesion. Okay. So, at the same time in the same shoulder, when somebody is getting erosion of the anterior glenoid rim plus Bankhart's lesion plus Hill-Sachs lesion, the same time, that is called terrible triad or unhappy triad of shoulder, because 100% that shoulder dislocation will go for recurrent shoulder dislocation and prognosis is not that good. So patient is unhappy and the surgeon is unhappy. So it's called unhappy triad of shoulder, otherwise called terrible triad of shoulder. This does not have any special name. Okay, this is called terrible triad of shoulder. There are two more terrible triads. Okay, there are two more terrible triads. So this is terrible triad of shoulder, we had finished. Another thing is called terrible triad of elbow. What is terrible triad of elbow? Radial head fracture. Elbow dislocation. Coronoid fracture. In the same elbow at the same time, somebody is having a radial head fracture plus elbow dislocation plus coronoid fracture. That is called terrible triad or unhappy triad of elbow, and this goes by a name called Hotchkiss triad. Okay. So, this is the second terrible triad in orthopedics. When you know three terrible triads in orthopedics, all terrible triad MCQs are over. Okay, so terrible triad of shoulder we had finished. This is terrible triad of elbow. Radial head fracture plus elbow dislocation plus coronoid fracture is called Hotchkiss triad. Otherwise called unhappy triad of elbow. It will go for a floating elbow. Prognosis is bad. Okay, yes. Now, the X-ray signs of shoulder dislocation. The third terrible triad, I am keeping it in suspense because that is coming as a separate MCQ. Okay, when it comes, you will understand that. Terrible triad of knee. Okay, terrible triad of knee. It's coming. Next, it's another MCQ is coming. Okay, so that's why I didn't touch it here. See, X-ray. What are the X-ray signs of shoulder dislocation? You see this X-ray, read this X-ray. All these X-rays are X-ray AP view of the shoulder. X-ray AP view of the shoulder. You look at this first diagram. You look at the first X-ray. This X-ray. I am able to see the glenoid cavity here, head of humerus. When you carefully see, the glenoid is not very clearly seen. The head of humerus overlaps, superimposes on the glenoid. So, head of humerus is lying in front of glenoid. Head of humerus is lying in front of glenoid. So, this is called anterior shoulder dislocation. This is the most common type of shoulder dislocation, anterior. The next X-ray, I am able to see glenoid cavity very clearly. Okay, separate. I am able to see the glenoid cavity very clearly. Totally easy. There is no superimposition of the head. Head is lying separately. That means head of humerus is lying behind the glenoid cavity. So this is called posterior shoulder dislocation. Posterior shoulder dislocation. Dear friends, there are no named signs. Anterior shoulder dislocation is the most common type, but there are no named signs for anterior shoulder dislocation. Posterior shoulder dislocation is a rare type, but it is having two named X-ray signs. That's what I want to teach. Repeatedly asked question in NEET. Okay, you see, this anterior shoulder dislocation has no name. Nothing. You are not able to see the glenoid cavity clearly. In an X-ray, there is superimposition of head over the glenoid cavity. It is anterior shoulder dislocation. Okay. If the head of humerus lies behind the glenoid cavity is seen very clearly and it is empty. Yes or no? It's seen very clearly and it is vacant or empty. That is why this is called vacant glenoid sign. Vacant glenoid sign. Vacant glenoid sign. Some books uses the word empty glenoid sign. So empty glenoid sign or vacant glenoid sign is a feature of posterior shoulder dislocation. Okay, posterior shoulder dislocation. Right. Now, look at the next thing here. The glenoid cavity is here, it is seen, and this head of humerus appears exactly like a bulb. Our old Philips 40 watts bulb. This is a 0 watts bulb, I think. So, okay, right. This looks like this is not a fracture, dear friends. This is a immature skeleton. Epiphysis is not fused. So it's looking like that. Is it not looking like a bulb, light bulb? So this is called light bulb sign. This is called a light bulb sign. So what are the two named X-ray signs of posterior shoulder dislocation? Empty glenoid or vacant glenoid sign. Another sign is light bulb sign. Okay, two named signs are only for posterior shoulder dislocation. Then, if it is a case of recurrent shoulder dislocation, the recurrent shoulder dislocation is divided into two types. One is called TUBS. Another is called ambry. Again, for your thing, just one eye is here. Okay. So, TUBS and ambry. For your remembrance sake, just I had given you a mnemonics. Shoulder dislocation, whenever a recurrent shoulder dislocation patient comes to you, you should be able to differentiate whether that's a TUBS type or ambry type. Okay. So, TUB means, T stands for traumatic. The etiology is trauma. Some history of fall or some injury, some accident, trauma. U stands for unilateral. Unilateral means, this is very basics, all of you know. Again, I will tell you, shoulder dislocation is of three types. Anterior shoulder dislocation, posterior shoulder dislocation, inferior shoulder dislocation. So, shoulder dislocation can happen in three directions, dear friends: anterior, posterior, inferior. In recurrent shoulder dislocation, what is defined a recurrent shoulder dislocation? Dislocation happening more than 2 times in a speculated time of 12 months, that is called a recurrent shoulder dislocation. So every time when the shoulder dislocates, it's going only in one direction. For example, first time anterior, second time anterior, third time is also anterior. That is called unidirectional. Other way around, first time it is anterior, second time it is posterior, third time it is anterior, fourth time it is inferior. It is multidirectional. So, in TUBS type, it should be traumatic and it should be unidirectional. Only in one direction it should go. If it is posterior, all the time posterior. If it is anterior, all the time it is anterior. Then it is called unidirectional. It's not unilateral, sorry. It is unidirectional. Okay, traumatic, unidirectional. B stands for MRI shows a Bankhart's lesion. When it is traumatic, unidirectional, MRI shows a Bankhart's lesion, treatment of choice is surgery. There are 151 procedures that are mentioned for recurrent shoulder dislocation. It says that no procedure is that convincing, but you should know 2 names at least. Common surgeries done for recurrent shoulder dislocation: Bankhart's operation, Putty-Plot's operation. Please, at least these 2 names. Okay, Bankhart's operation, Putty-Plot operation. Bankhart's and Putty-Plot's. At least these 2 names, it's enough. That is the treatment of choice if it is TUBS type. The exact opposite to that is ambry. A stands for atraumatic. No history of trauma at all. M stands for multidirectional. Here B doesn't stand for Bankhart's, bilateral. R stands for rehabilitation. I stands for inferior capsular shift. This is given in 6 pages when you read Campbell. No, we had made it so simple for you. The second type, if the patient says that coming with recurrent shoulder dislocation, no history of trauma, atraumatic, each and every time it is going one direction, one time anterior, one time posterior, multi-directional, and both the shoulders are involved, bilateral, the best treatment is physiotherapy. Don't do surgery. That's called rehabilitation. Okay, only for unidirectional traumatic we are doing surgery. This is rehabilitation. When you do surgery, it won't improve. If at all you do a surgery, one old surgery that is available, you are shifting the capsule inferiorly. That's called inferior capsular shift. Just you know the point, that's all. If they ask a question, best treatment for atraumatic multidirectional rehabilitation, physiotherapy. Best treatment for unidirectional traumatic, it is surgery. Okay, that completes to some extent recurrent shoulder dislocation. Yes, look at the next important question. You see here, a 36-year-old pedestrian was hit by two-wheeler on lateral aspect of the knee. This is fibula is here. So here, coming a dash, lateral aspect of the knee. He had fallen down to the ground with sharp pain and he couldn't get up immediately. He couldn't get up because of instability and severe pain with huge swelling. Maybe hemarthrosis. Look at the picture and tell your diagnosis. Look at the picture, tell your diagnosis. Is it anterocruciate ligament injury? Is it posterocruciate ligament injury? Is this meniscal tear? Is it terrible triad of knee? Okay, you just see here this diagram very simply. Anterior cruciate is broken here. Anterior cruciate is broken here. Medial collateral is broken here. Medial menisci, a small part, okay, it is torn here. So there is injuries, 3 injuries. Anterior cruciate is gone, medial collateral is gone, medial menisci is gone, and this is called terrible triad of knee. This is called terrible triad of knee. Okay, it goes by a name. You see, normal anterior cruciate, this is medial collateral, this is your medial menisci. So when anterior cruciate is gone, medial collateral is gone, medial menisci is gone. You look at here, direction from the lateral side, a direct hit by a two-wheeler or some force on the lateral side, anterior cruciate is cut, medial collateral is cut, medial meniscal is cut, and this is called terrible triad of knee, otherwise called unhappy triad of. How to pronounce that? Spelling is O-D-O-N-O-G-H-U-E. How to pronounce that? It's an Irish word. It's not English word. It's an Irish word. It's pronounced as O'Donoghue. Okay, how to pronounce that? It's terrible triad or unhappy triad of O'Donoghue. O'Donoghue. That's the pronunciation. Okay, and again, why it's called unhappy? The treatment is obviously it's arthroscopic repair. Prognosis is not good because there is, if you don't treat, no, it will go for permanent instability. Okay, that's why it's called. So 3 unhappy triads we are completed today, dear friends, in orthopedics. All the 3 unhappy triads completed. Unhappy triad of shoulder, unhappy triad of elbow, unhappy triad of knee. Right. Look at the next picture. Carefully read the question. A 30-year-old, look at the line, illiterate patient after sustaining injury to the right upper limb went to a native treatment, traditional bone setters, native treatment, where she was given an inappropriate tight bandaging. Now she has presented with severe pain with numbness of hand. On examination, pulse is felt feebly. Stretch pain present. That is one thing is enough to say this. What do you mean by stretch pain? For example, no, some inappropriate to the upper limb. When I extend the hand like this, severe unbearable pain on the flexor aspect of the forearm, molar aspect of the forearm. That is called stretch pain. So, what's the diagnosis? Very clearly it says, we know the diagnosis. All of you definitely would have diagnosed this. This is an often repeated INI-CET question. The answer is compartment syndrome. The answer is compartment syndrome. Compartment syndrome is otherwise called Workman's ischemia. Okay, compartment syndrome is otherwise called Workman's ischemia. What do you mean by compartment syndrome? Increased intracompartmental pressure, causing compression of the blood vessels, causing vascular compromise. If you don't treat at this stage, it will cause necrosis of the muscle, and end up in fibrosis of the muscle and shortening phenomena. Once it's established, that's called Workman's ischemic contracture. You can't do anything after that. Workman's ischemia, when you just interfere in time, you can save the limb. Okay, so compartment syndrome is otherwise called Workman's ischemia. An established condition is called Workman's ischemic contracture. Now let us see few points. What are the 5 classical clinical pictures of compartment syndrome or Workman's ischemia? They are called famous 5 P's. Famous 5 P's. First thing, earliest thing is pain. That is called stretch pain. Earliest thing is called pain, stretch pain. Number 2, pallor. Number 3, pulselessness. Pulselessness. Okay. Number 4, paresthesia. Number 5, paralysis. Exactly all the features there are several times in our Indian entrance. Dear friends, famous 5 P's of Workman's ischemia or compartment syndrome. Stretch pain is the earliest symptom. Okay, MCQ. This is an MCQ. Earliest symptom. Pallor, pulselessness, paresthesia, and the last thing is paralysis. What is the first muscle that is involved in compartment syndrome? 10 lakh times repeated question. Answer is flexor digitorum profundus. FDP. Flexor digitorum profundus is the first muscle that is. Okay, I told you raised intracompartmental pressure is the cause for compartment syndrome. The most common cause for compartment syndrome is inappropriate tight bandaging of the forearm by traditional bone setters or native treatment. That is why all of you, if you have completed house surgery, you know that whenever some forearm fracture, the most common site of compartment syndrome is volar aspect of the forearm. The most common muscle that is involved is flexor digitorum profundus. Okay, and the most common cause is inappropriate tight bandaging. Most common cause in a child is supracondylar fracture. Most common cause in adult is both bone forearm fracture. You see, that is why in ortho clinics and whatever in ortho OP, when forearm fracture comes, what we will do? We won't give cast directly. What is the difference between slab and cast? When you are applying a plaster of Paris, 2/3 with plaster of Paris, 1/3 with bandage, that is called a slab. When entire circumference is with POP, that is called a cast. So we will never use cast first. We will give a slab. Why? To prevent compartment syndrome. 1 week later, we will do what is called cast conversion. We will reinforce the slab into a cast. Okay. So that in the very beginning, immediate stage, after injury, hematoma formation, many things will be there. There is chance that intracompartmental pressure may go up. When you again tightly compress that with externally also with your cast, what happens? It will end up in compartment syndrome. That is why we won't give directly, we won't apply cast. We will do slabbing first, then we will do cast conversion. First must be FDP. There is a special manometer, mercury manometer. It's an old method to measure the intracompartmental pressure. This is nowadays everything is digital. Okay, so digital we can measure. What is the normal intracompartmental pressure? The standard textbooks, your MCQ guides are giving certain wrong answers. The standard textbook says 10 to 20 mmHg. This is the normal intracompartmental pressure. When anything exceeds 20 millimeter mercury, that is called a compartment syndrome. It should be treated. Okay. Yes. Now, there is a classification for Workman's ischemic contracture, Hughes classification. It is type 1, type 2, type 3. Type 1, only FDP, flexor digitorum profundus alone is involved. Type 2, FDP plus flexor pollicis longus, FPL, plus flexor digitorum superficialis, FDS. Only flexor digitorum profundus, it is type 1. Flexor digitorum profundus plus flexor pollicis longus plus flexor digitorum superficialis, that is type 2. All these three, FDP plus FPL plus FDS plus wrist flexors plus thumb flexors, they are called type 3. What is type 1? Only FDP. Type 2, FDP plus FPL plus FDS. Type 3, all the 3 muscles with wrist flexors and thumb flexors. Only if it is type 3, it will show you the classical this deformity. Okay, this is the classical thing of Volkmann's ischemic contracture, this classical deformity, and the classical sign is called Volkmann sign. The classical sign is called Volkmann sign. What do you mean by Volkmann sign? The fingers, they are like this. When you pass the fingers, everything flux like this. When you passively flux the wrist, fingers get extended automatically. When you leave, it will go like this. When you flux, it will be extended. When you leave, it will go. So this is called Volkmann sign. Volkmann sign is positive only in Fuchs 3. This was a question. That is why I am explaining. This was a question. Volkmann sign is positive in type 1, type 2, type 3, type 4. This was the choice. Answer is type 3. In type 1 and type 2, you won't get Volkmann sign. Right? And if it is a compartment syndrome, if you want to save the limb, what you are doing is, just you see, you are taking a 22 blade, cutting the skin, subcutaneous tissue, and you are dividing the deep fascia. This is called emergency fasciotomy. What happens when you do emergency fasciotomy? The intracompartmental pressure is released. So circulation, everything is established, and it's a limb saving surgery. When you do emergency fasciotomy, you will prevent this Volkmann's ischemic contracture. Okay, timely intervention. And the emergency fasciotomy is not a heroic surgery. It doesn't need an orthopedician, plastic surgeon, or general surgeon, house officer's procedure. Anybody having a 22 blade, just cut it 10 centimeters, deep incision, skin, subcutaneous tissue, deep fascia. Pressure is released, limb is saved. Okay. And you can put loose stitches to the skin. You should not stitch the deep fascia. You should just approximate the skin, loose stitch to the skin and dressing. This anybody can do. Yes. We will move on to the next important topic, dear friends. I think you are able to see there a nice diagram. Concentrate on this diagram. This is a lower conjunctiva. What is shown is a lower conjunctiva. A 27-year-old college student met with a violent RTA. High velocity injury, that's the meaning. Sustained fracture shaft of femur. Okay, 24 hours back. This happened 24 hours back. Okay, a day back. Now presented to the ICU with dyspnea, difficulty in breathing. On examination, there is lower conjunctival petechiae. That is pathognomonic sign. That is the gold standard sign. When you get a word lower conjunctival petechiae, there is no second differential diagnosis, dear friends. The diagnosis is fat embolism, otherwise called ARDS. Fat embolism, otherwise called. Look at the lower conjunctiva. This question was an image-based question. This is the original question that has been asked in INI-CET. Original question. Okay. See, lower conjunctival petechiae, rash. You are able to see here. 1, 2, 3. Lower conjunctival petechiae. The diagnosis is confirmed, it is ARDS, because usually the symptoms starts after 24 hours and within 48 hours. Most common cause is fracture of the long bone, especially shaft of femur in young adults. In elderly, the most common fracture that predisposes fat embolism is pelvic fracture. All these questions have been asked. In young adult, it is shaft of femur. In elderly, it is pelvic fracture. And you should know GERD's criteria. You should know GERD. Whenever a word is coming, that question is about fat embolism. Very simple. Major, minor. Petechial rash of the lower conjunctiva. Oxygen saturation less than 60. X-ray shows bilateral chest changes. See here, you are able to see some small dots like this, multiple small micro dots like this. Is it not looking like something? This is called snowstorm appearance. Okay. Snowstorm appearance of the lung, fat embolism. ARDS, fat embolism. Okay. So when you read this from Robbins, he will give you many synonyms, man. Fat embolism, ARDS, traumatic wet lung, shock lung. Okay. So all these are synonymous. In orthopedics, we stick on to one term. I don't want to confuse my student. Fat embolism. Okay. Yes. And major criteria, 1 is petechial rashes in the lower conjunctiva, 2 oxygen saturation less than 60, X-ray shows a classical snowstorm appearance. Cerebral symptoms unrelated to head injury. This is very important. Okay, there will be mental confusion, but definitely no head injury. So, three things, major criteria. Minor criteria, there will be tachycardia, there will be pyrexia, there will be oligoanuria, fat globules in the sputum, a high ESR and a jaundice. And book says that when you get one major, 4 minor, diagnosis is confirmed clinically. Okay, diagnosis confirmed clinically. And so far what we had seen is called GERD criteria. My question is, dear friends, my question is, do you know what is GERD test? Do you know what is GERD test? Okay, so that's why this thing, do you know what is GERD test? Okay, huh? A blinking like smiley, GERD test, because I am expecting this question so soon, because they had asked GERD criteria. In fact, about this asked question, this is an expected question. GERD test. GERD test is a bedside investigation, very simple investigation, 100% diagnostic of fat embolism. What is that? You take, just once I will tell, please listen. You just take 5 ml of patient's venous blood. Collect 5 ml of patient's venous blood. You are suspecting fat embolism in that guy. 5 ml of patient's venous blood. Take a Merslin cloth, a velvet like cloth, and my professor used to say, take dark black, jet black in color for contrast. Take a black color Merslin cloth. Pour the 5 ml of patient's venous blood over that. The blood will drip, will get sedimented. If it is a case of fat embolism, what happens? No, over that black color, that cloth, with your naked eye, you can see micro golden yellow fat globules directly, naked eye. That's a direct evidence of fat embolism. That's a direct evidence of fat embolism. That is called GERD test, which is an excellent bedside test for diagnosing fat embolism. Fat embolism, coming to treatment, there is no separate slide, just I will tell you, prevention is better than cure. Once it has started, it will take its own course. Prognosis, it is, you can't guarantee on prognosis. The things that are tried, you are giving anticoagulants like your low molecular weight heparin, you are giving plasma expanders like dextran, and fine, last but not the least, a good ventilatory support, okay, till the symptoms reside. Yes, coming to the next question. A 20-year-old Lulu had a road traffic accident, sustained injury to the right leg, He was brought to the emergency department with bleeding from his legs. On examination, his wound measured 11 centimeters, that is the point. His wound measured 11 centimeters, that is the point, okay. The bone is exposed and the soft tissue seems to be viable. Soft tissues are viable, it's not dead. Dorsalis pedis is felt easily, pulse is felt. What type of compound fracture he belongs to? Very simple, dear friends. I will tell you the answer, then I will teach you how to classify compound fracture or open fracture. Again, a guaranteed question in INI-CET. You see, 11 centimeters, it should be type 2. It should be type 2. It should be type 2. Okay. It should be type 2. Okay. So, the classification is called Gustillo-Anderson's classification. The classification is called Gustillo-Anderson's classification. There are 3 classification systems now currently available for compound fracture. One is Gustillo-Anderson, another is called Cherene, another is called Ganga compound fracture score. Okay, but we should know the most widely followed, which is accepted by most books, which is widely followed currently. That is Gustillo-Anderson. So that's why they are repeatedly asking. It is classified into type 1, type 2, type 3. Type 1, wound less than 1 centimeter. There is no devitalization of soft tissue. Soft tissue is not dead. Type 2, wound more than 1 centimeter, less than 10 centimeters. There is no devitalization of soft tissue. Type 3, wound more than 10 centimeters, there is devitalization of soft tissue. Type 3 is subdivided into type 3A, that is a compound fracture, there is adequate skin coverage. The wound is more than 10 centimeters, there is devitalization of tissue. When you cut all the dead tissue, you can close with the same skin. That is called type 3A. Type 3B, inadequate skin coverage. It needs skin grafting. That is type 3B. Type 3C, what is the meaning? associated arterial compromise, associated vascular damage, arterial compromise, right? It's an orthopedic emergency. For example, anteritibial is cut. Okay, it is type 3C. See, one more point I want to tell you, dear friends, the size doesn't matter. Even the size is 2 centimeter. Anteritibial is cut. Directly it goes to type 3C. Directly goes to type 3C. That's why in the question I mentioned pulse dorsalis speed is palpable. That means there is no vascular injury. Okay. So that is very important. It's an orthopedic emergency. This is called Gustilo-Anderson's classification. So just I used to remember like this. Type 3 ABC subdivision. No, type 3A only orthopedician is enough because you can close with the same skin. Type 3B needs skin grafting. So orthopedician plus plastic surgeon. Type 3C, there is arterial injury. So orthopedician plus a vascular surgeon. Just like that somehow. Okay. So this guaranteed slide, a question will come from this. Kindly again go through this, make notes. Coming to next question. Look at the X-ray and you should diagnose. A 40-year-old woman had a history of slip while climbing down the steps. She sustained an inversion type of injury to the left foot. Next day morning, she had severe pain and swelling over dorsum of the foot. X-ray shows the following finding. Diagnosis, please. See, as far as this is a foot X-ray, this is 5th metatarsal, 4th, 3rd, something like that. So I am able to see a fracture line in the 5th metatarsal. It's not too close to the joint. So the diagnosis is, this is called Jones fracture. Okay, Jones fracture. In the choice, no, you are seeing a Jones fracture, March fracture, Dancer's fracture, pseudo Jones fracture. 4 things are there. Don't worry. Easily in one slide I'll make you clear all these fractures. Okay, Jones fracture. Look at this diagram. Please concentrate. The first thing, this is a picture of 5th metatarsal. That's why 5th metatarsal. It is divided into 3 zones. 1, 2, 3. This is called zone 1, zone 2, zone 3. Okay. When you see very carefully, zone 1 is close to the joint. Zone 1 is very close to the joint. So any fracture that is happening in zone 1 is called pseudo Jones. Fracture that is happening in zone 2 is called Jones fracture. Anything happening here in zone 3 is called Dancer's fracture. All the 3 fractures are happening in 5th metatarsal, dear friends. When something is happening in zone 1, that's called pseudo Jones. Zone 2, that's called Jones. Zone 3, that's called Dancer's. Okay, Dancer's. You see this X-ray now. This is happening in zone 1. Yes or no? This is happening. There is a fracture line I am seeing in zone 1. And the book says that pseudo Jones means zone 1 is very close to the joint, no? So they will have intra-articular extension. So intra-articular fracture in zone 1 is called pseudo Jones. What is pseudo Jones? Intra-articular fracture that is happening in zone 1 is called pseudo Jones. Extra-articular, you see here, if this is zone 2, definitely this is far away from the joint. Only fracture is there, there is no intra-articular extension. Okay, so extra-articular fracture that is happening in zone 2 is called Jones. What is pseudo Jones? Intra-articular that is happening in zone 1 is pseudo Jones. Extra-articular that is happening in zone 2 is called Jones. Okay. Extra-articular long spiral or oblique happening in zone 3 is called Dancer's. In 5th metatarsal, when a fracture happens like this, this is called Dancer's fracture. Because ballet dancer very often develops this fracture. Okay, ballet dancer. So it's called Dancer's fracture. Then one more choice was there, March fractures. See here I am able to see the 1st metatarsal, 2nd, 3rd, 4th, 5th. I am able to see in shaft of the 2nd metatarsal, I am able to see a fracture here, and that is called March fracture. A hairline fracture which is happening in shaft to To be very precise, neck of second metatarsal, that is called march fracture. So we have completed the metatarsal fractures, dear friends. 3 fractures can happen in 5th metatarsal. It could be pseudo-Jones, it could be Jones, it could be Dancer. And 1 fracture can happen in 2nd metatarsal, that is called march fracture. March fracture is otherwise called hairline fracture, otherwise called stress fracture, otherwise called fatigue fracture. Okay, yes. So these metatarsal fractures are over. We'll see the next important, 10 lakh times repeated question. To me, according to INI-CET, this is the most important area, this slide. Okay, yes. A 25-year-old executive had insidious onset of right knee pain. Insidious pain means patient can't explain how it started, when it started. Then it is called insidious onset. Clear-cut onset won't be there. Patient or patient's attenders can't clearly say how this pain started, when it started. Then that is called, the type of onset is called insidious. The pronunciation is insidious. It's not insidious. It's insidious. Okay, so a 25-year-old executive had an insidious onset right knee pain. On examination, severe tenderness over the right knee. No gross swelling. Only pain is there. Gross swelling, examiner is not able to make up. The X-ray showed the following finding. Diagnosis, please. Wow, classical X-ray, man. What an X-ray. You see, this is the lower end of femur. This is upper end of tibia. I am able to see something like this. Something like this. Able to see. This is called sun ray appearance. This is called sun ray appearance. And the classical diagnosis is osteogenic sarcoma. Classical example is osteogenic sarcoma. Osteogenic sarcoma, why I don't think I had given myositis ossificans here. All other 2, Ewing sarcoma, osteoclastoma, all are tumors. This is not a tumor. I had not given irrelevantly, dear friends. Radiologically, clinically, you cannot differentiate osteogenic sarcoma from myositis ossificans. That's why I had given that. That's the closest possible DD. If they ask in exam, closest possible differential diagnosis for osteogenic sarcoma, you won't believe it is myositis ossificans. And there is a method to differentiate that. I will tell you. Right? You see here. You see the X-rays. Okay. I can't teach in detail because my time is limited. They say it is, I can maximum 2, I should finish within 2.5. That's the limit. Okay, I can't teach you extensively, right? So it is there in that free videos, I think in Prepladder videos, it's there. You see, because this is such an important topic. Osteogenic sarcoma alone, minimum will take 45 minutes of discussion. Okay, the tumor alone. So many points are there. But I will highlight and I will go. You see, this X-ray, whenever you see, you are seeing 4 X-rays here. This is an anteroposterior view of knee joint. This is lateral view of knee joint. You are able to see something going out like this. This is classically called sun ray appearance. This is called sun ray appearance. These 2, sun ray appearance. Okay, sun ray appearance. Some books uses the word sunburst appearance. Both are same. Sunburst appearance, sun ray appearance. When you carefully see here, dear friends, here periosteum ends here. After periosteum, you are able to see some ray like thing. Okay, X-ray can detect only bone and calcium material. It cannot usually that easily, it can show you soft tissues that easily. Okay, so how this is possible? The mechanism I will tell you, the concept alone I will tell you. You will never forget in your lifetime. Sarcoma. This is a classical feature of osteogenic sarcoma. Sun ray appearance is a classical feature of osteogenic sarcoma. 2 features are there in osteogenic sarcoma. One is sun ray appearance, another is Codman's triangle that I will show you here. Codman's triangle. You see, sun ray appearance, how this is happening. Sarcoma means a vascular tumor. Sarcoma means a highly vascular tumor. So, center of the tumor will be here, sarcomatous tumor. Sarcoma means lot of blood vessels, lesions of blood vessels will move towards the periphery. From center, lot of blood vessels, okay, will move towards the periphery like this. Okay, will move. Here is the vascular tumor. Lesions of blood vessels will go. Blood vessels you can't see in the X-ray. Microcalcification happens along wall of the blood vessel. Microcalcification happens along the wall of the blood vessel. Okay, So these microcalcifications you are seeing as a sunburst or sun ray appearance. This is the concept. This is the classical sun ray. Guaranteed an X-ray or image will come like this in our INI-CET, dear friends. Don't miss. 1 mark. Check. Okay. So sun ray appearance, osteogenic sarcoma. The next radiological appearance of osteogenic sarcoma is called, you see, the bone, the periosteum ends here. Okay. And the periosteum here is elevated. Okay. Here the periosteum becomes normal. Here it's normal. In this portion it gets elevated. This is the bone. This is the elevated periosteum. Is it not like a triangle? So this elevated periosteal reaction in osteogenic sarcoma is called Codman's triangle. Codman's triangle. Codman's. Okay. C-O-D-M-A-N. Codman's triangle. Now I am going to tell you, dear friends. Okay. Codman's. This is the spelling. Please take down. Codman's triangle. So this is nothing but a periosteal reaction. So periosteal reactions, what are the differential diagnoses? This type of X-ray where what are the situations, you will see exactly like this. Number 1, osteomyelitis. Osteomyelitis. Number 2, scurvy. Number 3, syphilis. Number 4, myositis ossificans. Okay. So whenever you see a periosteal reaction, elevated periosteum like this, 4 things should cross our mind, dear friends. Osteomyelitis, scurvy, syphilis, especially congenital syphilis, myositis ossificans. All these will cause elevation of periosteal reaction. But the word Codman's triangle is reserved only for periosteal reaction caused by osteogenic sarcoma. This is the point I want to stress. It is like your evening rise of temperature, dear friends. Evening rise of temperature happens in all fever, all the viral fever, bacterial illness, wherever it is, there will be evening rise of temperature. But the word evening rise of temperature, somehow it is reserved for tuberculosis. Yes or no? Like that, periosteal reaction can happen in osteomyelitis, scurvy, syphilis, myositis ossificans, osteogenic sarcoma. 5 conditions periosteal reaction can happen. The periosteal reaction that caused by osteogenic sarcoma is called Codman's triangle. Okay? Yes. You will move the previous, here you are able to see another calcified mass. Okay, this is also distal end of femur. This is also distal end of femur. Calcified mass is there, but it is not attached to the periosteum. It is somewhere here. This is a classical picture of myositis ossificans. Now coming to the next thing, X-ray, you are able to see in the uppermost portion of the tibia, small bubbles like thing. Yes or no? See? This is called classical soap bubble appearance. This is called soap bubble appearance. Soap bubble appearance is characteristic of, right? Soap bubble appearance is characteristic of giant cell tumor, GCT, otherwise called osteoclastoma. Osteoclastoma. Okay. So sun ray appearance means osteogenic sarcoma. Codman's triangle means osteogenic sarcoma. Soap bubble appearance means osteoclastoma, otherwise called giant cell tumor. Okay. When you just see very carefully the previous X-ray, you see here, very interesting, man. Ortho is very interesting. See, this is epiphysis. From here it is metaphysis. From here it is diaphysis. Mostly this is in the metaphysis. This is in the metaphysis, not involving the epiphysis. Osteogenic sarcoma happens in metaphysis. Whereas giant cell tumor, you see, the lesion is in the very much in the epiphysis. Okay. So giant cell tumor happens in epiphysis. In all bone tumors, you should know where it is originating. Osteogenic sarcoma, metaphysis. Giant cell tumor, epiphysis. Ewing's sarcoma, diaphysis. Med. Sure question. Okay. So osteogenic sarcoma metaphasis, giant cell tumor epiphysis, Ewing sarcoma diaphysis. Okay. You see here. So this is classical soap bubble appearance which is seen in giant cell tumor. Giant cell tumor. Look at this picture. In diaphysis, I am able to see, I should not draw and show, it will obscure the view. You see something has bitten, some radiolucency here. That portion alone something has bitten. So this is called moth-eaten appearance. Moth-eaten appearance. Very classical of Ewing sarcoma. Very classical of Ewing sarcoma. Moth-eaten appearance. Why I am stressing this point is, dear friends, they had asked the next question several times. Moth-eaten appearance so far unasked in any of the Indian entrance. So I am expecting this question soon. Radiological appearance. There are 3 radiological appearances in Ewing's sarcoma, dear friends. One is moth-eaten, not asked so far. Another is called cracked eyes appearance, not asked so far. The third popular thing is onion skin appearance or onion peel appearance. You see, this is a real onion. When you just, when you peel it, you will get in layers like that. When you carefully see this, periosteum is just stripped in layers. I am able to see multi-layers of periosteum. I don't know whether clearly, when you just zoom and see, multi-layers of periosteum like an onion peel. So this is called onion peel appearance. Onion peel appearance. Very, very classical of Ewing sarcoma. 1 lakh time asked question. I am expecting moth-eaten appearance and cracked eyes appearance very soon in the case of Ewing sarcoma. So Ewing sarcoma, 3 radiological features. Osteogenic sarcoma, 2 radiological features. Osteoclastoma or giant cell tumor, 1 radiological feature. Okay. So then comes the next important image. Again, very favorite question of exam setters in NEET, INI-CET, all the previously state entrances. This was the very favorite question. Look at the age, a 16-year-old pubertal age, 16-year-old male student presented to ortho OPD with chief complaints of bony hard swelling on lateral aspect of his right knee for the past 2 years. The swelling gradually increased in size. No dramatic improvement, gradually increased in size. Okay, without pain. He is more bothered about the cosmetic appearance, and X-ray showed the following lesion. You see, this is the lower end of femur. From lower end, an outgrowth is there like this with a pedicle. Okay, with a pedicle, outgrowth is there like a pedicle. X-ray shows the following. Diagnosis, please. Very simple. Pubertal age group, male patient, lower end of femur. No pain, gradually increase in size. The only diagnosis can be the most common primary benign tumor of the bone. What is that? Osteochondroma, otherwise called exostosis. That's the answer. Exostosis. That is the answer. Okay. So exostosis, that is called osteochondroma. That is the answer. You see, the thing I had given differential diagnosis, enchondroma, chondroblastoma, osteoid many things are there. Okay. Very simple. Enchondroma, most common site is phalanges. Fingers, metacarpals, phalanges. And it happens in the cancellous bone, inside the bone. En means inside, exo means outside. The exostosis is coming outside. You see, exostosis is outside. This is inside. You are able to see an osteolytic lesion inside the fingers, phalanges. Yes or no? Osteolytic lesion inside the fingers. So that is very classical of enchondroma. That's very classical of enchondroma. Okay, enchondroma. Number 2, chondroblastoma. It happens as an osteolytic lesion in the epiphysis. This is an osteophytic lesion. It's an osteolytic lesion happening in the fingers, phalanges. This also happens in the long bone around knee joint, but it happens in the epiphysis. Osteolytic lesion that's happening in the epiphysis, chondroblastoma. Okay, chondroblastoma. Chondroblastoma, the MCQ they are asking is where it happens, epiphysis. Enchondroma, tubular bones of that is metacarpal, diaphysis. Okay, this happens in the epiphysis. Exostosis or osteochondroma happens in the metaphysis. Osteoid osteoma happens in the diaphysis. In benign tumors, again, you see enchondroma, diaphysis, chondroblastoma, epiphysis, osteochondroma or exostosis, metaphysis, Osteoid osteoma, diaphysis. Okay, you see, now chondroblastoma, it's an osteolytic lesion. The epiphysis happens in children 10 years, average age 10 years. What is the thing classically? What does it gives pathologically, histopathologically? It gives what's called a chicken wire appearance. This they had asked several times. On chondroblastoma means the only question they're asking is chicken wire appearance. Chicken wire appearance. Okay, you should not forget. And exostosis, this is called cauliflower appearance. This is called cauliflower appearance. And I'm dear friends, pain should not happen in exostosis. Pain should not happen in osteochondroma. It's a painless condition. When pain happens in osteochondroma, you should suspect three things: bursitis of the osteochondroma, fracture of the osteochondroma, malignant change of the osteochondroma. Okay, in simple, only the points I'm telling. I can't take it in detail because osteochondroma has so many points. Okay, right? So this is cauliflower appearance. Then osteoid osteoma that happens in diaphysis of the long bone, especially tibia. The classical question they will ask you, the hallmark of osteoid osteoma is nidus. Nidus. So the classical presentation the patient will present to you is night cries. Night cries. Patient will go to bed, will be in deep sleep, suddenly disturbed by the pain. Okay, because the nidus means inside the osteolytic lesion a seed-like thing will be there. Okay, it secretes prostaglandins, cause severe pain during night time. Prostaglandin secretion from the nidus, severe pain. It disturbs the patient's sleep. He will cry out pain. Mostly this happens especially early morning. Whenever a word night cries comes in orthopedics, dear friends, whenever a word night cries comes in orthopedics, dear friends, think of skeletal tuberculosis first, osteoid osteoma next. Two differential diagnoses for night cries in orthopedics. Look at this nice picture. A 3-year-old male child brought with chief complaints of failure to thrive. On examination, the anterior fontanelles was not closed. 3 years, anterior fontanelle not closed. The first diagnosis you should see. Look at the clinical picture of the child diagnosed. When God has given us two fontanelles, dear friend, one is posterior fontanelle, another is anterior fontanelle. Two sutures, a sagittal suture and a coronal suture. Okay. And the posterior fontanelle should close by birth. At the maximum, it should close by 6 months. That's why the book says 0 to 6 months. It should be closed. Anterior fontanelle should close by 12 months. At the maximum, it should close by 18 months. Okay. If the fontanelles are unclosed after 18 months, the first diagnosis in the whole world is rickets, rickets, rickets. If fontanelles remains unclosed even after 18 months of age, the first differential diagnosis is rickets. Okay, so that is the diagnosis, rickets. So this guy, you see, failure of the pot belly. A pot belly is there. When you carefully note here, you can see the ribs, everything you are seeing a sulcus like thing. Okay, that is called Harrison sulcus. That is called Harrison sulcus. I will show you the picture. You see, what are the clinical manifestations of rickets? Fontanelles remains unclosed even after 18 months. The second, frontal bossing. You see the picture, classical frontal bossing, right? Then the baby may be having here, it is blurred, it is not seen here. I will explain. Okay, it is the picture, it's blurred, it's not seen here. I will explain. The ribs, no, beaded ribs, that's called rachitic rosary, beaded ribs. Okay, and the diaphragm gets attached to one place. There is invagination of diaphragm because of muscle wasting. You can see a groove, that's called Harrison's groove. That's because of pull of the diaphragm, the chest wall muscle. Okay, that's called Harrison's groove. And beaded ribs is called ricketic rosary, other is called rachitic rosary. So beaded ribs can happen in two conditions, dear friends. One is rickets, another is curvy. Here it's called ricketic rosary, there it's called scorbutic rosary. How to differentiate? When you touch, there is no tenderness, it is ricketic rosary. When you touch, there is severe tenderness, that is scorbutic rosary. Okay, and the beads, the end of the beads are blunt, it is rickets. When the ends of the beads are sharp, that is curvy. Very simple. Harrison sulcus, pot belly. And in the skull, no, I can see when I press the skull, craniotabes, that's called ping pong skull, craniotabes, and that's called McEwan sign, MacEwans, McEwan sign, McEwan sign, its spelling is McEwan's. This is the spelling. McEwan's sign. Okay, like your McEwan's. Some professors pronounce it as Messy-Wan. Okay, Messy-Wan's. Messy-Wan's triangle, McEwan's sign. Okay, so craniotabes, McEwan's sign. That's called crackpot sign or ping pong skull. Craniotabes means, what is the basic pathology of rickets? Rickets is vitamin D deficiency before epiphyseal closure. Osteomalacia is vitamin D deficiency after epiphyseal closure. This is the simplest way of defining. So in rickets, what happens because of vitamin D deficiency? The osteoid formation is normal, mineralization is defective. So the bone is very pliable and very plastic, So when I press, the skull will go down. When I release, it will come up. That's called ping pong skull, or that's called Messy-Wan sign. That's called McEwan sign. Then coming to the limb things, the baby can have a genu varum or bow leg. The baby can have a genu valgum or knock knee, or one side genu varum, another side genu valgum. This is called wind-swept deformity. Wind-swept deformity. When you come across wind-swept deformity in orthopedics, two differential diagnoses, dear friends. One is rickets, another is rheumatoid arthritis. Okay. So these are all asked MCQs. As far as possible, I'm going only in MCQ angle. Same time clinical and more towards MCQ angle. Yes, wind-swept deformity. Yes, coming to X-ray changes. Thickening and widening of the growth plate. Cupping of the metaphysis. You see, this is called cupping. See the depth of the metaphysis gone like this. It's called cupping of the metaphysis. Then splaying of the metaphysis, widening of the metaphysis. Then comes a looser zone, which is stamp of osteomalacia. Looser zone, you see here, stress fracture happening here. This is called looser zone. This is called hallmark of osteomalacia, looser zone, right? The looser zone is otherwise called milkmaid fracture, milkman fracture, stress fracture, it is hallmark of osteomalacia. Stamp of osteomalacia. The word stamp of osteomalacia is given in aptly. So it uses the word stamp of osteomalacia. And the biconcave vertebra, this is otherwise called codfish vertebra. Okay, codfish vertebra, osteomalacia. Whenever you come across a word biconcave vertebra or codfish vertebra, two differential diagnoses, dear friends. Multiple myeloma is one differential diagnosis. Osteomalacia is another differential diagnosis. Then you can get a trefoil pelvis, otherwise triradiate pelvis, and very peculiarly spontaneous fracture of ribs. A rib fracture has to happen. Some injury has to happen, some trauma has to happen. This is one situation in the whole world, without any injury, spontaneous fracture of rib happens in somebody. Okay, just for a joke, I used to tell my students, very seriously preparing for entrance, sitting at night, 12 o'clock, taking notes, tap, 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 sound happening, multiple rib fractures happening spontaneously. Just imagination, you are having vitamin D deficiency, okay? Yes. Identify the test picture given here. Favorite question of INI-CET. I don't know what is there, but they are asking this several times. Okay. Patient lying like this, flexing the hip and flexing the normal side. Okay. And he is able to get an angulation like this on the on the normal side. This is he is flexing the normal side. The affected side he is getting a thing like this. What is this test? This is called Thomas test. This is the right answer, Thomas test. What do you mean by Thompson's test? Comes in tendo-Achilles rupture. Squeezing, okay, tendo-Achilles rupture. Moses test comes in deep vein thrombosis. Homan's test also comes in deep vein thrombosis. So this is Thomas test. Thomas test is used to diagnose fixed flexion deformity of hip. That's all. This is the only point you should know. How to do and all, it's not important. Okay, normally suppose for example, I am having right-sided fixed flexion deformity of the hip. When I lie down in the supine position, it should not have a bed. This is wrong. There should not be any bed. It should be a flat surface directly over the steel cot. Bed should not be there. You flex the unaffected side. What happens now? Slowly, normally when there is fixed flexion deformity, when you see like this, there will be exaggeration of lumbar lordosis. You will see a tunnel like thing. When you flex the hip, right? the tunnel should go away. At the same time, flexion of knee should not happen. If you have fixed flexion deformity, however much the fixed flexion deformity you are having, when the lumbar lordosis get obliterated, you will get that equivalent flexion deformity of the knee. Okay, so how to do it is not important for you. Once we become PG and ortho PG, we will do that. Okay, you should know Thomas test is used to assess fixed flexion deformity of the hip. Okay, fixed flexion deformity of the hip. Many causes are there for fixed flexion deformity of the hip joint. Look at the next diagram. A 28-year-old male presented with chief complaints of low back ache associated with morning stiffness. There is and morning stiffness exaggerated with rest. So all this stiffness, pain gets exaggerated with rest, improves with activity, vanishes with activity, improves with activity. Very peculiar, no? Most of the pain situation or stiffness situation, when you take rest, that should improve. Here, worsening with rest, improves with activity. That is the clue. Okay. And he also complains of tightness of chest. What could be the probable diagnosis? Obviously, low back ache, male patient, age group 28. Pain and stiffness worsens with rest. Diagnosis is ankylosing spondylitis, HLA-B27, ankylosing spondylitis. Okay, see this X-ray will give you the diagnosis. You see how it looks like. Lumbar spine, classically it looks like this. Okay, this is called, dear friends, bamboo spine. This is called bamboo spine. Okay, this is called bamboo spine. Just for you should know this criteria, Newark criteria for ankylosing spondylitis. 3 months, minimum of 3 months. In rheumatoid arthritis, all we say is 6 weeks, 6 weeks. 3 months of inflammatory back pain that improves with exercise, worsens with rest. Golden point. Limitation of lumbar movement in both frontal and sagittal, front and back as well as sideways. Limitation of lumbar movement. Okay. Number 3, limitation of chest expansion. Okay, rib cage, chest expansion. Bilateral sacroiliitis. It requires one clinical, one radiological feature. The classical radiological feature is called bamboo spine, compared with the bamboo. Okay, it's called a bamboo spine. Exactly like this, you will get image like pictures, diagnose the case. Okay, this is bamboo spine. Then, next important, very simple thing. A 65-year-old postmenopausal woman, that itself gives a diagnosis. Postmenopausal means you should be having osteoporosis. Okay, this itself will say the diagnosis, osteoporosis. Postmenopausal woman was traveling in last seat of the bus. She had a history of jolting, just like that. 3 days later, she presented with back pain. Now X-ray shows the following feature. The lateral aspect of the lumbar spine, the X-ray I had taken. You just see normal shape of this vertebra. No, it is a rectangle, something like this. Yes or no? You see what happened here? The spine had become wedge shaped. Spine has become wedge shaped. This is called wedge compression fracture. Wedge compression fracture, most of the time pathological fracture. What do you mean by pathological fracture? Fracture happening in a bone which is already having a pre-existing pathology. What is the commonest pre-existing pathology? A bone can have osteoporosis. Metastasis is rare. Malignancy is rare. Osteoporosis happens in all elderly individuals. Okay, weakness of bone. Okay, osteoporosis, right? So this is a pathological wedge compression fracture that has happened. The diagnosis is obviously osteoporosis. Similar X-rays several times they had asked in INI-CET, dear friends. That's why wedge compression fracture. Okay, you see. Now, carefully concentrate. You will understand many things. I'll make it so simple for you. You see, this is femur, tibia, fibula. That's okay. Whenever you see a bone, I am teaching you simple radiology. I can't teach like a radiologist. To my orthopedician knowledge, I can teach you in a simple fashion, dear friends. Whenever you see an X-ray, 2 things you can notice very easily with our naked eye. Okay, one is called a cortex. This white color structure is called a cortex. The whole thing is called medulla. Medullary canal. The whole thing is a medullary canal. The thick white structure, these are called the cortex. Okay, I think I am clear. This is a normal X-ray of a knee. Okay, you are able to see a normal thickness of this cortex, normal thickness of the cortex, normal medullary canal. This is normal. You see here, I am not able to see cortex at all. The cortex is so thinned out. I am not able to make anything. Here I am able to see this much thickness. Here I am not able to see any cortex in that. So this is called pencil thin cortex. This is called pencil thin cortex. Okay, pencil thin cortex. Whenever you see a pencil thin cortex, the diagnosis is osteoporosis. Osteoporosis. Pencil thin cortex. Okay. Exactly opposite to this. Exactly opposite to this. Okay. One thing has happened here in this X-ray. This is also a tibia X-ray. Cortex has become so thick. This is one cortex. This is another cortex. Medullary canal size is decreased. You compare this with this man, normal cortex, medullary canal. Here you see the whole thickness is a cortex. This is another cortex. Medullary canal is so much narrowed. You're able to see. So cortex is thick, medullary canal is thin. The diagnosis is osteopetrosis. Osteopetrosis. This is otherwise called, osteopetrosis is otherwise called marble bone disease. Osteopetrosis is otherwise called marble bone disease, otherwise called Albrecht-Schönberg's disease. Robbins only gives this much synonyms. Ortho books ஒரே word. Osteopetrosis. Only one word. Osteopetrosis. Okay, osteopetrosis is otherwise called marble bone disease, otherwise called Albrecht-Schönberg's disease. Okay, so what happens? Pencil thin cortex, widened medulla, no cortex or thin cortex, osteoporosis. Very thick cortex, very narrow medulla, osteopetrosis. Look at the third diagram. I am not able to differentiate where is cortex, where is medulla. Everything appears just uniform. Here I am able to see this is the cortex, this is the medulla. In this area, I am not able to see which is the cortex, which is the medulla, and this is called corticomedullary differentiation is lost. This radiological feature is called loss of corticomedullary differentiation. The diagnosis is chronic osteomyelitis. Many things we have completed in one slide, dear friends. I repeat once again. 3 O's in orthopedics. I taught you. Osteoporosis, osteopetrosis, osteomyelitis. Thin cortex, widened medulla, osteoporosis. Thick cortex, narrowed medulla, osteopetrosis. Corticomedullary differentiation is lost, osteomyelitis. Okay. So this is osteoporosis of a long bone. This is vertebra. This is osteopetrosis of a long bone. Osteopetrosis happening in the vertebra. You see the vertebra. See how thickened it is. Okay, sclerosed. The differential diagnosis for this is Rugger jersey spine that comes in hyperparathyroidism. Okay. Yes. So just a quiz for you, Prepladder quiz for you. If someone answers this question correctly, probably we will contact Prepladder and ask for some gift. Okay. Yes, Prepladder quiz. This X-ray also shows you pencil thin cortex. I think you are able to see very clearly. This X-ray also shows you a very pencil thin cortex. Cortex is very thin. Okay. Very thinned out here. Pencil thin cortex. What is the diagnosis? Because pencil thin cortex means we had studied just now, it is osteoporosis. Okay. Yes, there is a catch in this question. Okay, right. You see, when I see very clearly, the epiphysis is not closed, so it's a child. Okay, and I am able to see a white line here. Okay, a white line here. Carefully now you watch a white line. That is called white line of Frankel. That's called white line of Frankel. Now the diagnosis will change from osteoporosis to scurvy. The diagnosis is scurvy. Why I am teaching in this fashion? Whenever a question pencil thin cortex comes to you, two differential diagnoses should come to your mind, dear friends. If epiphysis is closed and it's an old patient, only pencil thin cortex you are seeing, the diagnosis obviously osteoporosis. When you see an epiphysis not closed, no, osteoporosis is very rare, no, in children. You are seeing a white line, that means it is because scurvy causes osteoporosis. Scurvy causes osteoporosis, but it is associated with some other thing also. White line of Frankel. White line of, you are seeing a white line like this. I don't know whether it's clear in your camera. I don't know, just zoom and see. White line here. Okay, so this is called this white line. I will draw and I will rub it. Just watch it again. You will understand. This white line is called white line of Frankel. In the diagnosis is, dear friends, that is scurvy, vitamin C deficiency. All these things are expected. Okay, in this INI-CET you see it will come. Look at the following diagram and give your diagnosis. This is something about, because a very favorite question of INI-CET, Seddon's classification of nerve injury. Look at the following diagram, give your diagnosis. Is it neuropraxia, axonotmesis, neurotomesis, axonopraxia? Okay, so obviously, just I am convinced there is no such term called axonopraxia. Just I want to give fourth choice. Okay, obviously I want to go to the answer directly. You see, this is intact. Only the axons are cut. Only the axons are cut. Classical representation of axonotmesis. Okay. So, Seddon's classification 1943, three types: neuropraxia, axonotmesis, neurotomesis. Just I will read very fastly. We'll go. Neuropraxia, this is a transient episode of complete motor with little sensory paralysis. Temporary physiological disruption. There is no anatomical disruption. Physiological disruption of nerve impulse. Complete recovery is the rule. It is thought to be local reaction to ischemia that results in non-induced conduction block. No Wallerian degeneration, because there is no anatomical damage. How can you expect Wallerian? No Wallerian degeneration. Tinel sign is negative. Recovery begins within 2 to 3 weeks. Complete recovery 8 weeks is the rule. This was the question that asked. Usually nerve requires dash weeks after neuropraxia, 8 weeks. Example is a Saturday night palsy, crutch palsy. Okay, Saturday night palsy, okay, radial nerve palsy, neuropraxia, stretching, that's all. No anatomical damage, you see, no anatomical damage. Physiological disruption of nerve impulse. Second is called axonotmesis. This is more severe injury involving loss of continuity of the axon. Continuity of the axon, okay. With maintenance of continuity of the outer sheath. Motor, sensory and autonomic paralysis is complete and denervated muscle atrophy can progress. Wallerian degeneration is seen, Tinel sign positive and progressive. So when Tinel sign is positive and progressive, it is axonotmesis. Motor march is seen, recovery is never complete. Example, closed fractures and dislocation. This needs some intervention. Neurotomesis, worst thing in Seddon's classification. This is complete transection of nerve, total cut of nerve. It is commonly seen in severe lacerated injuries. Tinel sign positive, non-progressive. Spontaneous recovery is not possible. Requires nerve repair. Even many times nerve repair also won't give. So this needs tendon transfer. Most of the time tendon transfers. Okay, right, transfers. Usually it widely separate. If widely separated ends, it forms proximally neuroma, distally glioma. Okay, we will go to the next thing. Comment on the following diagram. What is this test? Comment on this. Again, very frequently asked test, this diagram in INI-CET exam. Comment on this test. A patient is standing with one leg raised like this. Okay, so this is, what is this? What is this test? This is called Trendelenburg's test. This is called Trendelenburg's test. Trendelenburg's test, it says that, see, normally what happens, no? This is normal. When patient raises one leg, both the iliacus, everything should be in the same line. If there is weakness of gluteus medius, when the patient raises one leg, no, the opposite side, the normal side will go for dip. Iliacus will go for dip. This is called Trendelenburg sign. Drop pelvis with lifting of the opposite to the weak. This is weak. This is due to weakness of the thigh abductors, mainly gluteus medius. Okay, mainly gluteus medius. Superior gluteal nerve can be involved. Test by having patient stand on one leg. Pelvic sags on contralateral side when standing on the affected side. This is the test. They won't ask you again like Thomas, how to do is not important. What are the conditions? Trendelenburg sign will be positive. One, it is due to thigh abductor weakness. Okay. It can be positive in neck of femur fracture. Old neck of femur fracture. Okay. So, two situations Trendelenburg test is positive. Abductor weakness of the hip and thigh. Old non-union fracture neck of femur. In these two situations, your Trendelenburg test is positive. Look at which of the following method is depicted in the picture. Obviously, this says, obviously this is a club foot. Slowly this is corrected, slowly corrected, and it is made straight. This is the classical Ponseti's method. This is the classical Ponseti's method. Ponseti's method and Kite's method both are manipulative methods, corrective methods for CTEV, congenital talipes equinovarus. Ponseti's method is serial correction. Ponseti's method is serial correction. This is at a stretch. Okay. This is not a serial method. You are correcting at a stretch. Okay. So this is Ponseti's serial correction. You are doing Kite's method. At a stretch, you are correcting all the deformity. Turco's method, Dillon events, I will tell it in the next slide. You see this. Congenital talipes equinovarus is 50% bilateral, more common in male babies, polygenic inheritance. Many theories are there. The most accepted theory is primary germplasm defect of the talus. So, talus is not formed fully. Talus, the shape and size of the talus is altered. It's going for congenital talonavicular dislocation, CTV. Okay. Structural changes are so more evident in talus, to some extent in calcaneum. Three classical deformities of talipes equinovarus, otherwise called club foot, is equinus at ankle, varus at subtalid joint, forefoot adduction or adduction of the torsometatarsal. Torsometatarsal joint is called forefoot. Calcaneum is called hindfoot. So, equinus at ankle, varus at subtalid joint, and forefoot adduction. These are the three classical deformities of congenital talipes equinovarus, otherwise called club foot. It is compared with a golf club, so it's called a club foot. Okay. And how to treat? See, what are the associations of CTEV? Recollect. Exam goers, recollect. What are the associations of congenital talipes equinovarus? Most common association, meningomyelocele, otherwise called spina bifida, very common. Poliomyelitis, another common association. Okay, lateral popliteal nerve palsy, another association. Arthrogryposis multiplex congenita, another association. Tibial hemimelia or absent tibia on one side congenitally, that's an association. These are the associations. Repeatedly they are asking spina bifida and CTEV in the entrance. Kindly watch. Okay, please read the topic fully. Right, coming to treatment, should begin as soon as birth. CTEV baby is born, begin as soon as birth. It should be corrected in the following order. This is very important. Forefoot adduction corrected first, inversion next, equinus last. First, second, and this is last, third. When you change the order, it will end up in a catastrophe. When you change the order, it will end up in a catastrophe. Forefoot adduction first, inversion next, equinus last. When you change the order, it will end up in a catastrophe. What? It will lead on to, when you change the order, it will lead on to what is called a rocker bottom foot. Rocker bottom foot. Because rocker bottom foot. When you change the order, it will end up in rocker bottom foot. Rocker bottom foot, whenever like a rocker bottom, a horse, children will be playing, like a rocker bottom. It will be like this, rocker bottom. It's called a rocker bottom foot, right? Whenever you come across rocker bottom foot in orthopedic MCQ, two differential diagnosis, dear friend. One is wrongly corrected CTEV. Ponseti method, you are doing it wrongly, number one. Number two, rocker bottom foot. Congenital vertical talus, which is seen in Edward syndrome. Okay, which is seen in Edward syndrome. Right, Edward syndrome. So, congenital rocker bottom foot, two differential diagnosis. Wrongly corrected CTEV, congenital vertical talus, CVT. Where it occurs? Edward syndrome. Okay, chromosome 18, Edward syndrome. Okay, right? So this is the order, and use minimum force of correction gives a better functioning foot, right? Foot is for age-wise treatment plan. You should say, just you take down this alone for your INI-CET, 0 to 8 weeks, 8 weeks to 5 years, 5 years to 10 years, more than 10 years. Surely one question will come. This is given in 6 pages. I made it into 4 lines. Please concentrate. 0 to 8 weeks manipulation by mother and by Ponseti's method. Ponseti. Okay, Ponseti's method. Correction. 8 weeks to 5 years. This is not corrected with Ponseti's method. Again, CTV is, again, it's looking the same. It's not improving. That is called a resistant CTV. So you should go for soft tissue correction. That is called posteromedial soft tissue release, PMSTR. Probably all these things in detail you would have read. This posteromedial soft tissue release is called Turcos method. Turcos method. Okay. So it should get corrected. All the soft tissue you can try only with the baby till 5 years. 5 to 10 years, once it has crossed 5 years, your posteromedial soft tissue release won't help. You should go for bony reshaping of the calcaneum and the talus. That is called Dillwyn-Evans method. Dillwyn-Evans method. Okay. Once the baby has crossed 10 years, that is called neglected CTV. None of this method will help. You have to go for what is only one thing that is left out. It's called triple orthodesis. Triple orthodesis. Triple orthodesis means you are fusing 3 joints. Talonavicular, calcaneocubar, subtalar. 3 joints are fused. Talonavicular, calcaneocubar and subtalar joints are fused. This is called triple orthodesis. Okay. So these are the modalities. So 0 to 8 weeks Ponseti method, manipulation by mother, and Ponseti method. 8 weeks to 5 years you can try soft tissue, posteromedial soft tissue release, that is called Turcos method. 5 years to 10 years you can do bony reshaping, that's called bony osteotomy of the talus and the calcaneum, that's called Dillwyn-Evans method. After 10 years you can't do anything to fuse the 3 joints to give a pain-free stable joint. That's all. That's called triple orthodesis. So more than 10 years a child is coming to you, or even by 10 years you are not able to correct, that's called neglected CTV. The only surgery that is available is triple orthodesis. Then diagnose, please. Look at the finger. Again, this is a INI-CET question. Look at the finger. The patient is able to flex all the fingers except the terminal phalanx. He is able to flex in all the fingers except in this ring finger. He is not able to flex the terminal phalanx. Okay. So what is the diagnosis? So the diagnosis, this is called jersey finger. This is called jersey finger. So you should know how to differentiate a jersey finger from a mallet finger. Okay. So when you know this, this is more than enough. Jersey finger, you see what happened, there is rupture of the tendon of flexor digitorum profundus. So rupture of flexor tendon causes jersey finger. Exact opposite to this, rupture of the extensor tendon, rupture of the extensor tendon of the terminal phalanx causes mallet finger. Okay, mallet finger happens in baseball players. When a ball comes and without expectation, okay, he is stiffly extending the finger. Suddenly a ball comes and hits, no, forceful flexion of the terminal phalanx causes rupture of the extensor tendon. Will end up in mallet finger. That's why mallet finger is otherwise called baseball finger, otherwise called drop finger, right? When a flexor digitorum profundus tendon get ruptured, okay, we are suddenly hyperextending the terminal phalanx, flexor tendon may get ruptured. That will end up in jersey finger. 2 opposite conditions. Jersey finger is flexor tendon rupture, mallet finger is extensor tendon rupture. Okay, yes. This is a diagram, mallet finger, there is a jersey finger. Mallet finger is a differential, it exactly looks like a swan neck deformity of the rheumatoid arthritis, dear friends. Yes. Yes, beautiful. This is again a very frequently asked question in INI-CET. See, I am able to see a boy. His hairline is very low and neck is short. And this is giving me, oh, hairline is low, short neck, down seems to be right, Turner seems to be right. Okay, so both the syndromes seems to be right. More than that, you see scapula on this side is normal. Here scapula is small and elevated. So that's called sprungle shoulder. So a short neck associated with sprungle shoulder, the only diagnosis in the whole world is Klippel-Feil syndrome. Klippel-Feil syndrome. Klippel, what do you mean by Klippel field syndrome? Klippel field syndrome, you see, this is a normal cervical vertebra. You are able to 1, 2, 3, 4, 5, 6, 7. Normally you are able to see cervical vertebrae like this. Here when you see, few are fused to form one block. Whole thing is fused. Yes or no? So they are not separate. So congenitally fused cervical vertebra is called Klippel field syndrome. Congenitally fused cervical vertebra is called Klippel field syndrome. 99% of Klippel field syndrome is associated with Sprengel shoulder. It's associated with Sprengel shoulder. They are asking very repeatedly this Sprengel shoulder and Klippel fields in INI-CET, that is AIMS, very frequently. Okay, so you just go and check your question bank. You will see this exact picture may come. So congenitally fused cervical. So how congenitally fused cervical vertebra? What will happen? Neck will become short, hairline will become low. Since you know pretty well the action of first cervical vertebra is called atlas, because the first cervical vertebra due odontoid process, the whole skull is on that, it is atlas. Second cervical vertebra, no, it is called axis, because that is responsible for this axial movement of the skull, axial movement of the skull. What happens, no, all the vertebrae are fused together. So when you call by name, no, the patient can't turn the neck like this, like a robot, the whole thorax he will move like this and see. That is how a Klippel field will present. And most of the time, 99% is associated with the Sprengel shoulder, classical. So see here the scapula is in normal size and in normal position. Here scapula is small and elevated. Okay, see low hairline, short neck, Sprengel shoulder, Klippel field syndrome. So scapula, in Sprengel shoulder, what happens? Congenital elevation of the scapula, developmentally scapula failed to descend from its neck. Most common association is Klippel field syndrome. Okay, yeah, if X-ray shows what's called in Sprengel shoulder, normally in fetal life, it will be in cervical area. As the fetus grows, the fetus grows, the scapula from cervical region has to descend down. That's the rule. But when there is persistence of omovertebral bone, the scapula fails to descend. It will be stuck to the cervical level. That is called Sprengel shoulder. Once you have diagnosed Sprengel shoulder, omovertebral bone should be cut. Omovertebral bone means you should not imagine that a thick bone or something like that. It will be a thickened fascia-like structure. That's all. I had seen and I had assisted only one case operated for Sprengel shoulder in Government Stanley Medical College, Chennai, long back. Okay, pediatric orthopedician. I was posted in Madras Medical College in Institute of Child Health. There Professor Manoharan was operating on case. Only one case I had seen operating. And you want, no, just you have to go and divide that omovertebral fascia. That's the only treatment. That's called Klissik procedure. That and all is not needed for you. That's just you have to go and cut the omovertebral bone. Okay. And the book says that, and practically it says that, and professor taught me that whenever you want to do a surgery, you should do it before 6 years. After 6 years, scapula, it won't come back. You can't expect improvement. I think this is enough for you. You should know what is Sprengel shoulder, what is Klippel field syndrome, how is the association. What is this test? What is this test? Okay, this is called Hoover's test. Hoover's sign or Hoover's test. Okay. Hoover's test, what it is employed, where it is employed, that's very important. Hoover's test or Hoover's sign is to differentiate organic hemiplegia from functional hemiplegia. If you know this, this is more than enough. I don't know why in ortho they are asking this several times in INI-CET. I don't know. I had seen the question bank, that's why I am telling you. Okay, I don't know why. This should be asked in general medicine because this test is explained in only Harrison, not in ortho book. Okay, Hoover's sign or Hoover's test is to differentiate hysterical hemiplegia from organic hemiplegia. Just only once I will tell you, please listen. Make the patient lie down in supine position. If there's we will take into account real hemiplegia patient, right? You, the examiner, you are having for example, I'm having left-sided hemiplegia. Okay, examiner keeps his palm underneath the right heel, normal heel, and I will ask the patient to lift the affected side, left side. Patient, he is having real hemiplegia. He is trying to lift, he couldn't lift because it's real paralysis. To compensate that, he will give a thrusting force on the normal heel, then it is normal. If it is hysterical hemiplegia, when you ask the patient to raise the left thing, she will behave as if she is trying to lift. At the same time, she will not give thrust on the normal heel. Then it is called positive Hoover's. Positive Hoover's. What is the diagnosis? Look at this. What is the diagnosis? I am able to see this is such a common condition in clinical practice. That's why INI-CET repeatedly asking. I am able to see a spur here, a spur here. This is called Hoagland deformity. This is called Hoagland deformity. The patient usually have a very severe pain over the insertion of the tendo Achilles, and this is associated with calcaneal spur. So patient will have heel pain. Okay, Hoagland deformity. So this is because this is a degenerative change. This is a degenerative change. This is because of repeated use or overuse of the tendo Achilles, right? And a predisposing factor for this is diabetes mellitus, right? Treatment, it's just giving rest, serratiopeptidase, all those things. A surgery is not recommended. And several times, okay, don't worry dear friends, I'll finish in 2 minutes, okay, 2 or 3 minutes. Very important thing. That's why, okay, so just look at this. What is this? This is called Milwaukee bracer. Milwaukee brace. This is called Milwaukee brace. When you see here, a chin support is there, occipital pads are there, bar is there, steel bar is there, lumbar support is there. These are the parts of Milwaukee brace. Milwaukee brace is given in two situations: scoliosis. Indications: scoliosis, Scheuermann's disease. Scheuermann's disease. Scheuermann's disease is avascular necrosis of the vertebral body. Avascular necrosis of the vertebral body. Only two indications are there. The only thing just I want to stress you, dear friends, dear friends, that this Milwaukee brace, when it is given before adolescent age. Milwaukee brace is given only for children, especially before epiphyseal closure. Once the full growth is attained in adults, it is useless and it is not advisable. Okay, it is indicated for congenital scoliosis, for Scheuermann's disease of the spine in a child or before adolescence. Okay, this you can expect. This will come. Asked several times. This is a classical bone holding forceps. This is a classical bone holding because all these are asked questions, asked image. That's why I am repeating bone holding forceps. The very purpose of this bone holding forceps is just to hold the bone. For example, I am doing open reduction, internal fixation of the radius and ulna. Okay, I had opened. I am seeing the proximal fragment, distal fragment. To reduce, how to reduce the proximal distal fragment? Only with bone holding forceps I can reduce it. Okay, that is the indication. This is a bone holding forceps. This is a classical bone nibbler. You are able to see, this is a classical bone nibbler. Okay, nibbles. So bone nibbler indication, it can nibble the mainly, for example, I am doing an open reduction internal fixation, a delayed case, 30 days old, I am doing, minimal callus will be there. So I want to break the callus, I have to nibble the callus, I have to do it. I have to nibble the unwanted bone, I have to remove. I want to nibble the sequestrum, I have to. So bone nibbler, okay, common indication. It's a classical bone nibbler. So this is, you see, this is called a rail fixator. Rail fixator is an external fixator. It's an X-fix only. Okay, but this is called LRS. LRS, limb reconstruction system. What is the indication for this LRS? LRS is mainly indicated in compound fractures. Compound fractures. So gold standard treatment. Infective non-union. Okay. Infective non-union. Infective non-union, Ilizaro is gold standard. Main indication for this is compound fractures. Limb reconstruction system. This is called rail fixator. Several times this diagram has been asked in INI-CET. Again we can get. Okay. So this is again a very favorite image in our INI-CET. You would have by this time. This is called what is called a cock-up splint. Cock-up splint. This is the this year NEET exam, last month exam, NEET exam. This was the question. Cock-up splint. Okay, cock-up splint. Two types of cock-up splint. This is called static. Here it is the spring and all. So this is called dynamic. You know the indication of cock-up splint, wrist drop, radial nerve palsy, wrist drop. See, you should give time. If it's a neuropraxia also, wrist drop will come. You should 8 weeks, you should give time, then only it will recover. 8 weeks when the limb is in this position, nerve will recover. What happens to this muscle will undergo contracture. To prevent that, no, you should extend and put a POP slab. Olden days we are putting a POP slab. Nowadays this is ready-made, this is available, and leave like this. Okay. So most of the time the patient should be wearing, out of 24 hours, minimum 20 hours the patient should wear. Okay, so this is called a static cock-up splint. Here spring is there. What happens? No, patient can flex, patient can't extend. So patient actively will flex the wrist, the spring will cause extension. Okay, so this is called dynamic cock-up splint. So static cock-up splint, dynamic cock-up splint, the indication is wrist drop due to radial nerve palsy. Okay, so I think, to my knowledge, I think I had done something, okay, in a possible time. Okay, I had not completed, but definitely, okay, so I know your agony, and this is what, in one way I can help you. Exam is fast approaching, definitely this will. I am a greedy teacher. I'll pray to God that the same question should be repeated in our INI-CET, so that all of our students should get a good seat. We can do it, man. Okay, we can do it. If possible, what I'll do, I'll just see the chat box. I will try to answer few of your questions. Okay, right, 1 minute, just be online. Only answers. So I had seen the chat box. Excellently, you have answered most of the questions. I'm very glad. Two of them, they had asked one common question. Sir, how to differentiate a Colles cast from scaphoid cast? Colles cast from scaphoid cast. I have shown you the picture. The Colles cast, no, it is like this. I will explain. In palmar flexion and ulnar deviation, below elbow POP cast in palmar flexion and ulnar deviation, that is called a Colles cast. I told you, when you give a Colles cast, that will, what I can say, neutralizes the dorsal tilt, dorsal displacement, lateral tilt, lateral displacement, okay, impaction and supination, because Colles cast is given in palmar flexion, ulnar deviation, in supination with the traction. This will look like this Colles cast. Whereas a scaphoid cast, no, thumb and radius is in the same line. I am not doing ulnar deviation, it's in the same line, and the thumb, no, it is in a glass holding. For example, I hold a glass like this, no, in glass holding position like this, up to thumb I will immobilize the thumb in scaphoid fracture. I will never immobilize the thumb in Colles cast. I will immobilize the thumb in scaphoid cast. That is called Bowler gauntlet cast. Okay, I hope you have understood. Okay, dear friends, all the best. Okay, I have strong hope that everyone will clear the INI-CET exam. Exam is very simple. Only thing is we have to plan. All the best. For any doubt or anything, no, just I am in Facebook with Prepladder. You free feel to ask me, even not only for orthopedics, for your motivation, because I know your pain, dear friends. I had undergone, okay, very severe pain during my entrance preparation. Now I am well settled, okay, good, doing well, fine. But I know your agony, because I can perceive what you are feeling now. Okay, right? I know very well, right? In my 17 years of entrance coaching, many students I had seen. Okay, so I love students, I love my juniors. Feel free to ask me doubts. Okay, thank you so much.